We, the we are family, strengthening primary healthcare together. Oh, whoa, man, oh, whoa, one, one world, one vision, one future, one.
Primary healthcare has long been recognized as the means to attaining health for all.
PHC is the key that unlocks UHC. When all people can access quality health services without financial hardship.
The roots of PHC extend far back in the WHO Southeast Asia region. This legacy predates even the Alma Ata Declaration, reflecting our region's long-standing value for primary healthcare.
Many of the countries that have responded most effectively to COVID-19 are those
We, the we are family, strengthening primary healthcare together. Oh, whoa, man, oh, whoa, one world, one vision, one future, one health, one home, one heart. In this Southeast Asia region, we are each other compare for the future of billion. Let's work together and leave no one behind. Where 1+1 makes 11, with joint partners and government. It's long journey, we are friends. Let's work together and leave no one behind. Health organization, it's on the foundation. World Health Organization, evidence and action. Me and you, and you, one world, one vision, one future, one girl, one goal. We, the we are family, strengthening primary healthcare together. Oh, whoa.
Check, check, 1, 2.
Work together and leave no one behind. Where 1+1 makes 11.
check, check, 1, 2, 3, 4, check, check.
Government.
Increase the volume. Check. Check, 1, 2, 3, 4, check. Mike, hello. Yep, good. Thanks.
Hello, testing. Mic 1. Hello. Amit, you can confirm. कंचन फॉरन पे बात सही जा रही है कंचन प्लीज कंफर्म
Test. Okay. We try to minimize the number of participation in this room. Only 1+2 from each country. From 1+2 from each country, and 10 from the secretariat side. So we will broadcast back to that room.
Hello, Amit. Mic 2 testing. Mic 2 testing. Okay. Hello. 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 नहीं आ रही है बस तो देर हेलो 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 दीपक आप देखना आप हेलो हेलो टेस्ट नहीं लगाया मैम हेलो टेस्टिंग 2 माइक 2 हेलो 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 अमित कैन यू कंफर्म अमित कंचन कंचन फॉरेन पे सही आ रही है अभी ओके हेलो 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 अमित माइक 3 कैन यू कंफर्म अमित हेलो कंचन कैन यू कंफर्म फॉरेन पे जाइए सही आवाज आ रही है फॉरेन पे दीपक हेलो हेलो कंचन एक बार कंफर्म कर दो यार फॉरेन पे आवाज सही जा रही है कैन यू जस्ट चेक
यस सर फॉरेन साउंड क्लियर है सर
वो लोगो वाला लगा
हेलो
लगा हाँ सीरो वाला होना चाहिए
हेलो
आवाज सही जा रही है फॉरेन पे
हाँ सर
माइक
वॉइस से
अच्छा व्हाट्सएप रहने देता हूँ तुम स्पीकर पर रहने देता हूँ ठीक है स्पीकर में म्यूट करके रख रहा हूँ तुमको माइक 3 ओके थैंक यू अमित
हेलो
हेलो अमित माइक 4 लो है आवाज थोड़ी लो है हेलो माइक 4 लो है आवाज थोड़ा सा बढ़ा लो ठीक है बस इसको फ्रीज कर दो सर थैंक यू
हेलो हेलो चेक 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 हेलो 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 हेलो
5 नंबर बस यहाँ पे एक बंदे देखो यहाँ पे प्लीज 5 नंबर अमित आवाज ओके साउंड क्वालिटी इज ओके थैंक यू हेलो अमित आर यू एबल टू हियर मी क्वालिटी इज ओके 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 नहीं वहां पे लगा दिया था ना उसको अमित वहां पे आप लोग देखो सर 3 जगह पे हाँ Hello. Hello. 7. Amit, quality is okay? Okay, thank you.
Okay. Yeah, that's fine.
Yeah, can you hear me? Can you hear me? Can you hear me? Yeah.
Hello.
Hello.
Amit, mic number 8.
Okay.
Quality
Yeah,
is
that
okay?
sounds fine. Yeah, that sounds fine. Yeah.
Thank you.
okay. Yeah. It's all right. I'm sure it'll be all right. Yeah. Do you need it to be that low? I would prefer it like that. Oh, I see. Okay. I see. All right. That's fine. That's fine. That's all right. I have some papers with me, so I want to. That's all right. I can manage that. I can hold them. That's fine.
Number 9. Okay.
It's up
Amit,
there.
quality is okay? Okay. Thank you.
Yeah, that's good. That's all right. And I use the Oh, right. Yep. Yeah.
And display setting also.
Well, then I can do that. Yeah.
Mic number 10.
That's all right.
Okay. Thank you. Amit, quality is okay? Okay.
That's what you'll have. And if there's any issue, I can do all right.
Hello. Hello. Amit, mic number 11. Okay, thank you.
So do I need to use?
Hello.
but I use
Amit,
it
mic
if I-
number 12. Thank you.
Oh.
Hello. Amit, mic number 13. Okay, thank you. Number 14. Hello. Hello, Amit. Voice quality is okay? Thank you. Thank you. All 14 okay.
Hello, hello. Yeah, goes okay. Yeah, sorry.
Check, check.
Hello, hello. Is it coming through? Hello, 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 hello.
Check 1 2 3 4. Check, 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 check. Check 1 2 3. Yeah, बहुत ज्यादा उसमें वो है. Can we have some another one? Check, check.
Is it okay?
No, it's coming up, but not too good. I just changed.
Check, check.
Check, check, check. 1 2 1. Check.
Hello, hello. Good. Thanks. Yeah.
So, am I clear? No, is it okay? Yeah. Can you hear me? Done okay? Yes, sir. Yes.
Okay, no?
Just Pemba. I'll make. Just, hello, can you hear me? Is it okay?
Yes.
Is it okay? Can you hear me? Hello, testing. Uh, 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 okay. Oh, hello, hello. 1, 2, 3, 1, 2, 3. Okay. 1, 2, 3, 1, 2, 3. Kukuta hai, did you? देखा है क्या?
That's that's
Yeah. Are you here? 1, 2, 3. What's that? Is it all right? Yes. 1, 2, 3, 4, 5. 5, 4, 3, 2, 1. 1, 2, 3, 4, 5, 6, 7.
Sir, did that switch on? It's mute, on mute. Yeah. His voice is. And
Yes,
how do you like me to address you, call you? Excellency.
Dr. Elia. I say Dr. Elia.
Elia.
Yeah, I say Dr. Elia. That's Elia. That's fine.
Elia is okay?
Yeah, it's okay. Hello, Dr. Kanam, how are you? Thank you. Thank you. So you, yeah.
You're going to post with Jerry.
I know. I will. Thank you. Yes, please.
And now in that, we can go to have overflow.
Yes.
Limited.
Good morning, everyone.
Yeah. Yeah, that's the one who asked me the
May I
question.
please ask you,
What is that? The question. The
colleagues
last one? What's
and
that?
delegates and distinguished guests, kindly, if you would be seated.
Access to care.
And I kindly ask all others
Oh,
who
second
are
one.
standing in the room, please, to move to the next room, next door, the spillover room where they are seating, and there will be the broadcast of the session, please. We wish to make a timely start, please, in about 1 minute.
Even as improve access, our focus on the problem must not improve, no? Segundo ronda. Yeah. Hello. Where are you from actually, Professor?
I'm a professor. I'm from the London School of Hygiene and Tropical Medicine.
What?
London School of Hygiene and
I
Tropical
thought
Medicine.
I see. Okay. One of my advisors is studying there at the moment. Yeah. Her name is Iris Hammerberg.
And do you know what is she doing about the program?
Yeah, no, PhD.
PhD?
Yeah. Yeah.
Something more less than.
No, she used to work in there, but now she just takes a year off to do her PhD work. Yeah, Professor, I might talk to you later. Professor. Thank you, Professor. I'm still laying. Need questa essere foto? Need questa essere foto? Need. Non so. No. Morning. I will. Yes, yeah. Thank you. Mike.
You have that color mic.
Ah, okay, I see. Is it on?
They will turn off from that side.
They will turn on there. They will turn on
Yep,
and
yep,
then I
yep,
start
yep,
to
yep.
do. Ah, I see. Okay, thank you. Hmm? Hmm? Say the name? Thank you, Amin. What's that? إنه شيرة موضوع هذا شيرة موضوع هذا بس ما يدري نن Yana vita luska. Oh halo terus sayang. Dua makanya resposta makiran itu tuh. Bisa dia sira dia pues my first question dan sira malega how maklay. Sira malega how maklay. Oh maklay nem how resposta. How bisa pergunta basira? Lah usir how lagi pergunta basira. Lah how lagi pergunta basira usune. Mas kala how lagi itu? How yang resposta lagi? Oh maklay. Ya. Sana? We're ready? Excellencies, WHO Regional Director for Southeast Asia, Dr. Punham Ketapal Singh, distinguished delegates, ladies and gentlemen, good morning and welcome to the second of the 76th session of the WHO Regional Committee for Southeast Asia. I'm informed that delegates heartily participate in the morning yoga session and enjoy the yoga. And I appreciate the work done by the organizer for arranging the wonderful session for the participants. And I'm confident that after the morning yoga, all the delegates are feeling fresh. Yes. And I'm pleased to welcome you to this very important ministerial roundtable session on strengthening primary healthcare as a key element towards achieving universal health coverage. Excellencies and distinguished delegates, I now invited the Master of Ceremony, Dr. Amani Siam, to take the floor.
Good morning. Thank you very much, Your Excellency. Good morning, colleagues. Good morning, delegates, excellencies, our WHO Regional Director of Southeast Asia, Dr. Punham Ketapal Singh, distinguished delegates, ladies and gentlemen. Please be seated for those of you who are still here. For others, please, if you're standing and there are no seats, kindly move over to the other room where there are seatings and there will be the live transmission as well. I would like to please begin this ministerial roundtable. I wish to introduce myself. My name is Amani Siam. I have the privilege to serve as a regional advisor for health information systems in the WHO Southeast Asia Regional Office. And it's my great honor to serve you today as the Master of Ceremony for this ministerial roundtable on strengthening primary health care as a key element towards achieving universal health coverage. With your permission, I would like to start this session by watching a short video on the momentum towards primary healthcare in the Southeast Asia region.
Primary healthcare has long been recognized as the means to attaining health for all.
PHC is the key that unlocks UHC. When all people can access quality health services without financial hardship.
The roots of PHC extend far back in the WHO Southeast Asia region. This legacy predates even the Alma-Ata Declaration, reflecting our region's long-standing value for primary healthcare.
Many of the countries that have responded most effectively to COVID-19 are those that have invested adequately in primary health care.
Evolving health challenges, the COVID-19 pandemic, and subsequent economic crisis have brought into sharp focus the imperative to strengthen PHC orientation of health systems. To support this effort, WHO launched the Southeast Asia Regional PHC Strategy, which, through elaboration of 7 values and 12 strategic actions, provides a unified framework for strengthening PHC in the region. Across countries of the region, there is strong momentum towards strengthening PHC orientation of health systems. While significant progress is underway across countries of the region, the vital question is how to ensure quality PHC across the variety of economic, geographic, and social contexts in which the 2 billion people of the region reside. At the Regional Committee in September 2022, member states called for the establishment of a regional knowledge and experience sharing mechanism through mobilizing expertise from development, implementation, and academic partners. The SEER PHC Forum was launched in November 2022.
There's so much that we can learn from each other, and we can certainly achieve so much more through collaboration than we can work individually.
Led by member states, with partners in support, the forum is a platform for implementation-focused knowledge exchange and collaboration. Through collective effort, the forum is capturing operational learning on member state-identified bottlenecks. It has also brought PHC actors in the region closer. The forum is growing organically, with new collaborations emerging since its launch. The essence of the forum is not in its own prominence, but rather in its role in harnessing knowledge that is already present in the region and the spirit of togetherness. Together, we have opportunity to advance the long-held vision for primary healthcare. While strong momentum towards primary healthcare is evident across the region, the challenges we face are substantial and evolving. Your guidance and leadership, including at this roundtable today, is needed to further strengthen primary healthcare as a key element towards achieving UHC, and in doing so, meaningfully contribute to making health for all a reality for the people of the Southeast Asia region.
Thank you. Thank you very much. And I would like to take this opportunity to thank the government of India, who have selected for us a crucially important topic to discuss together at this year's Ministerial Roundtable. We are very fortunate as well to say that in this year's Ministerial Roundtable, it will be moderated by Dr. Palita Abikun. I wish to give you a brief background about Dr. Palita. He is a public health icon in Sri Lanka, in our region, and globally. His established educational background spans esteemed universities in Sri Lanka, in Switzerland, in Southern California, and the Harvard School of Public Health. Dr. Palita serves as one of WHO Director General's Special Envoys for COVID-19 and a member of the WHO Global Pandemic Preparedness Monitoring Board. He's a former president of the Sri Lankan Medical Association, a member of the WHO Global Learning Academy, a former director of health systems and development in our own WHO CRO, as well as an acting WHO representative to India. I am very honored to actually ask Dr. Palita to really lead this discussion, and over to you, sir, for your interventions. Thank you.
For your very generous introduction. Madam Chair, Excellency Dr. Elia, Excellencies, distinguished representatives, the Ministerial Roundtable has now become an important event at the Regional Committee of SEAL. And it provides us with a unique opportunity at which Honorable Ministers of Health, as the highest decision makers within the health system, discuss issues of critical importance to this region. Your discussion today on primary healthcare, or PHC, sometimes I must confess is mistakenly perceived as to be of lower status than some other parts of the system. It's a mistake. It's the other way about. This signifies the value of PHC in addressing health and well-being in the context of economic and social challenges of our society. As was just highlighted in the introductory video we just saw, the history of primary healthcare is especially rich in our region. What is more, the countries of our region are also leading the current global drive towards renewed focus on primary healthcare as a cornerstone for achieving universal health coverage. At the recent UN General Assembly political declaration of the high-level meeting on UHC and the G20 New Delhi Leaders Declaration, both led by countries of our region, heads of state and governments committed to strengthen primary healthcare, and these stand as important examples. Today's discussion will build on these and earlier commitments, importantly from the experiences of your countries, and we will have ideas and opportunities to undertake both individual and collective action to strengthen primary healthcare across our region. To set the scene for our discussion, we have the honor of welcoming Dame Anne Mills, Professor Anne Mills, or Auntie Annie. I'm sorry, it's well known in Thailand, for example, as known by many in our region, has an unparalleled history in supporting the countries of our region. Dame Anne is a global health icon and is a professor of health economics and policy at the London School of Hygiene and Tropical Medicine. Her work has influenced major health policies, both at national and international levels, with a demonstration that proper investments in medicine and public health will have a major impact on social growth, economic growth, and social equality. The major focus of her work is on methods to provide efficient and equitable healthcare in low and middle income countries. In terms of awards and recognition, there are plenty, but let me mention just a few. Professor Mills was appointed a Commander of the Order of the British Empire, CBE, for her services to medicine in 2007. She was awarded the Prince Mahidol Award for Medicine in 2009 in recognition of her contribution to the development of health economics and health systems research in Africa and Asia. Professor Mills was elected a Fellow of the Academy of Medical Sciences and a Fellow of the Royal Society in 2009 and 2013, respectively. And she was appointed Dame Commander of the Order of St. Michael and St. George for services to international health in 2015. May I respectfully invite Professor Mills to provide a keynote message to this ministerial roundtable. Thank you.
Honourable Ministers, Regional Director, ladies and gentlemen, I'm honoured to address you on the subject of primary healthcare as the foundation of universal coverage. And I'm going to explore this through the lens of financing, since a good financing system is fundamental to good primary care. I'm going to address the importance of primary care, the challenge of primary care financing, and responses to the challenge. So first, the importance of primary care. There is strong evidence from across the world that comprehensive primary healthcare for all is the most efficient and equitable way of meeting all initial health needs, including the growing burden of non-communicable diseases. Primary care with, of course, referral to hospital as needed. For example, it's estimated that up to 75% of the projected health gains from the Sustainable Development Goals can be achieved through primary health care. In addition, higher government spending on primary health care is strongly associated with better universal health coverage service coverage. So this graph shows universal health service coverage on the vertical axis, primary healthcare expenditure per capita on the horizontal axis. And there is a clear association between higher spending and higher coverage. But note that outside the high-income countries, some countries are getting much more UHC coverage for a given primary healthcare expenditure than others. So that's the vertical, the difference on the vertical there, suggesting that some countries are converting a given amount of primary care per capita spending more efficiently into coverage than other countries. In terms of equity, benefit incidence analysis shows who benefits from healthcare. The majority of benefit incidence analysis studies in Asia Pacific show that the poorer population groups benefit more from primary care services than richer groups, whereas the use of hospital care is usually pro-rich. And this graph displays the results from these studies. The bars above the zero line indicate pro-poor service use, the zero line there. The turquoise bars are for primary healthcare, and most of these are above the zero line, indicating primary healthcare is pro-poor. And then finally, on the subject of the importance of primary healthcare, there is also good evidence that increasing public funding to expand access to frontline providers is the most efficient and equitable way of improving health outcomes and can encourage inclusive economic recovery. For example, Thailand's 30 Baht program introduced universal health coverage in 2001. Prior to universal health coverage, poorer provinces had significantly higher infant mortality rates than richer provinces. Universal health coverage increased funding to frontline providers via capitation payment. Healthcare utilization increased, especially amongst the poor, and the differences in infant mortality between poorer and richer provinces disappeared, most likely due to increased access to healthcare among the poor. I'm going to draw the material for my arguments from here on from the Lancet Commission on Financing Primary Healthcare, which reported in April 22. This was the work of global experts from national governments, academia, and global health agencies. It defined the primary healthcare financing challenge and how to respond, as shown on this slide. The challenge is limited priority given to health in public spending and political and professional pressures that favor hospitals. This leads to three key problems: insufficient funding for primary healthcare, funding often captured by hospitals, and primary care funding that is fragmented, inflexible, and inefficient. The Commission proposed three key responses: to allocate more resources to primary healthcare, to allocate equitably and ensure allocations reach the PHC level, and align funding flows and incentives. And this would produce better financing for people-centered primary care. And I'm going to briefly explain these 6 elements in more detail. The problem of insufficient funding for primary healthcare. Government spending on primary healthcare in lower middle income countries is very low. It's estimated that low income countries on average spend $3 per capita, lower middle income countries $16, upper middle income $73, and high income countries more than 10 times as much. The second problem is that this funding is often captured by hospitals. This slide shows current health expenditure by healthcare provider for 36 lower middle income country from 36 lower middle income country health accounts. And these orange bars here show spending on hospitals. I fully accept that the data are not fully comparable, but I think you can agree that the pattern is clear. Up to 60% of health expenditure is going to hospitals. The blue and yellow bars on this graph indicate primary healthcare spending through primary care units, sales of drugs, and so on. These blue and yellow bars may seem quite a high share of the total, but it's important to remember that hospital funding is generally organized and structured, whereas much primary care is provided by the unorganized private sector. So hospitals represent powerful stakeholders in resource allocation. And this then is the third problem, which is demonstrated here. The graphs, these 4 graphs, show PHC funding patterns by country income group: low income, lower middle income, upper middle income, and high income. These 3 bars in each of these 4 sets of graphs show government spending per capita on primary care, external funding, and then private funding in this third of the 3 graphs, private funding on primary care per capita. And the shading on these bars shows expenditure on medical goods in blue, that's medicines and diagnostics, spending on outpatient care in pink, and spending on prevention in turquoise. So the message I'm trying to make with these sets of graphs is that financing for primary care is highly fragmented, especially in low and lower middle income countries. There's low government spending and high out-of-pocket spending. So this set of graphs here, government and out-of-pocket. There's a high share of external spending in these countries. And put in rather crude terms, patients pay for drugs, donors for prevention, and governments for outpatient care. As countries grow richer, it's clear that the share of government funding comes to dominate. So this brings me to the 3 responses to the 3 challenges I've gone through. The first is to allocate more resources to primary healthcare. And I fully recognize that many of your countries have been through an economic crisis, a fiscal crisis, and face difficult financial circumstances. But I think allocating more resources for primary healthcare as a priority is critical. Important elements of this are that there needs to be clear allocation of responsibility for primary care within the Ministry of Health, and primary healthcare needs to be prioritized within government budget processes, especially when there is the possibility of allocating incremental increases in government revenue. Primary healthcare funding needs to be visible and capable of being tracked. The funding needs to be used to increase accessibility and quality of primary care services free at the point of use, to make them more attractive than paying out of pocket. And it's critical to include essential medicines in the service package, both to reduce out-of-pocket spending and to improve the quality of care. The second response is to allocate equitably and protect resource allocation down to the front line. A critical element of these recommendations are to introduce a budget line for primary care if this does not already exist, and to use population-related resource allocation formulae to allocate funding to the local level. In other terms, a capitation-based payment process. And capitation will link funding to the people to be served. Protecting resource allocation down to the front line is helped by allocating budgets, defining spending rules, giving local decision-making authority, but of course, monitoring the performance of the local units. In other words, there should be a strategic purchasing approach. As shown in this graph, this may need to develop gradually as management capacity grows stronger. For example, a country may start with simple capitation and allocation per capita of the population in the area of a health unit, and then add extra payments to incentivize, for example, preventive and promotion, and then eventually moving to more blended payment, which ensures that the government's priorities can be reflected in primary care expenditure. And then the third response is to align funding flows and incentives to make sure that the primary healthcare level is supported. This means integrating funding streams at the provider level. One of the marked findings of studies across Asia and Africa is how fragmented the funding flows are to primary healthcare. And so integrating them at the provider level is critical. Also harmonizing benefit packages, contracting and provider payment systems, reporting and monitoring. Many health units are paid in multiple ways for different purposes, and this makes efficient provision of services very difficult. And it's critical to encourage care seating at the primary care level, as primary care development permits, to require first access at that level, what we call a primary care gatekeeping system, which really can only be successful when the quality of primary healthcare is good. And of course, to ensure that payment systems and rules don't incentivize overuse of hospitals. And then also as part of the local health system, it's important to link the primary and the secondary care levels, since it's obviously clear that not everyone can be dealt with at the primary care level, but will need referring for more specialist care. So to conclude, these are my key messages to strengthen financing for people-centered primary care. Public resources should form the core of primary healthcare funding and should have first claim on funding when it's available. Pooled public funds should cover primary care first before other services are covered, and should cover essential medicines as well as other services. Resources should be allocated equitably and protected to reach frontline providers, and that is best done by capitation payment plus associated management processes. And finally, provider payment systems should be integrated with capitation at the core to support people-centered primary health care. Many thanks for your attention.
Thank you very much, Professor Mills, for your very valuable keynote address. There's so much distilled wisdom in that short message that you gave us. And I think it sets the stage beautifully for our roundtable to follow now. Thank you very much. Excellencies, now we have 2 rounds of this roundtable discussion. May I kindly request your Excellencies to kindly consider adhering to the given time, 5 minutes for the first round and 3 minutes for the second round, and it could be shorter, no issue about that. I will pose questions to the Excellencies, beginning with countries whose ministers are present here in alphabetical order. followed by other heads of delegations. For the second round, I'm going to reverse that order. May I start with you, His Excellency Zaid Malik? My first question to you is, Excellency, we know that primary healthcare is an important operational priority within Bangladesh's 5th Health, Population and Nutrition Sector Program. Building on the strong community clinic model, could you share with us key interventions that Bangladesh is making to further strengthen the primary healthcare in your country? Thank you.
Thank you. Oh, it is there. I was looking for the.
It's on your left.
Yes, yes. Thank you very much for the important question. So before I begin, I must address today's chair, Honorable Health Minister of India, Dr. Bharati Pawar, Vice Chair of this session. We have the Honorable Madam RD, Dr. Poonam Khetrapal, Honorable Ministers, esteemed delegates, ladies and gentlemen. Assalamu alaikum and good morning. Thanks for the important question that you have put to me. Primary health care is the key of a country's health system, which is considered as the kingpin in attaining universal health coverage and sustainable development goals by 2030. Our Honorable Prime Minister Sheikh Hasina initiated the community clinic concept in 1998 to provide primary health care to vulnerable members of societies, including the elderly, mothers and children. The United Nations General Assembly accepted this initiative as the Sheikh Hasina Initiative, recognizing the importance of community clinics in providing high-quality healthcare services for universal health coverage and to provide services to the doorstep of the people, especially in the rural areas. We already established more than 14,000 community clinics targeting 6,000 population for each clinic. The community clinic is a great illustration of a public-private partnership where locals contribute land and manage the community clinic. The government constructs building, deploys personnel and provides supplies including medicine and logistics. With the increased demand from the community people, the government has strengthened community clinics and taken several measures. About 45% of the deliveries in Bangladesh is home delivery, which is a vital case of maternal death. The government has expanded community clinics from 2 rooms to 4 rooms to ensure normal delivery in the clinics. As a result, under 5 mortality and maternal mortality has significantly reduced. To further strengthen and ensure continuous vaccination, community clinic has been allocated as EPI center also. All vaccine coverage in 2022 reached 98%. To reduce cervical cancer, Bangladesh has recently introduced HPV vaccine, and also community clinics will be used in some area in the rural areas for this vaccination. Non-communicable disease burden are increasing day by day, and mortality from NCDs is also very high in Bangladesh. To address this issue and diabetes, screening program has been initiated in community clinics. Screening program we have started in the community clinics. For this NCDs and diabetes, medicine will also be provided by care providers for patients having been prescribed by the doctors. Because in the rural areas, sometimes you don't get the medicine available at the doorstep. Digital technology, the community clinic has been provided with laptops and internet connections to ensure digital reporting, which guarantees to find out disease pattern and helps in data-driven policy making. Each of the community clinics are having this laptop, and they send the message of everyday issues. To address malnutrition and obesity of the children among children, community clinics provide counseling on food and nutrition, as well as ensure height and weight measurement. As a result, significant progress is made in reducing stunting and wasting rates among children under 5. Between 2004 and 2022, the prevalence of stunting decreased from 51% to 24%. And from 17% in 2004, the prevalence of wasting among children under 5 decreased to 11% by 22. Apart from community clinics, over 5,000 union health centers and family welfare centers provide similar kind of primary health cares. They provide also adolescent health care, was also emphasized for female hygiene practices, vision care, and psychological support also from there. We don't have similar health facilities in urban areas. To strengthen urban primary health care, a separate operational plan has been initiated with special attention to urban health. We are actively exploring alternative health financing options, increasing public investment in health, particularly for primary health care, to reduce catastrophic health expenditure. The government's dedication to primary healthcare is persistent, and these initiative marks significant steps toward a healthier, more prosperous Bangladesh. Together, we can ensure that quality healthcare is accessible to all, regardless of the location or economic condition. Finally, I take this opportunity to seek the support of the member state on the resolution on strengthening health emergency preparedness for disaster resulting from natural hazards. The resolution will be placed for adoption by the 77th session of the World Health Assembly. As one of the members of the core group, we believe this resolution will create space and scope for WHO and the member state to work effectively in addressing the challenges related to the health emergency caused by the natural disasters. Just before I stop, I like to quote that Dr. Poonam Khetrapal her statement that without financial hardship, the primary healthcare should be arranged and provide services, and also the countries who had got the primary healthcare strong, they also faced the COVID very effectively. So we also thought that in the COVID response, Bangladesh did quite well. And one of the main reasons is the community clinics that provided us the access to the people at the earliest, and there was less hospitalization, less morbidity, and reduced pressure on the health services. Thank you very much for the opportunity.
Thank you, Excellency. For your impressive list of achievements. May I next move to India? Her Excellency Dr. Bharati. My question to India would be, India has been a signatory to the Alma Ata Declaration in 1978 and the Astana Declaration in 2018. Both of these emphasize primary healthcare as a key to strengthening universal health coverage. What has been the journey of India in this direction? What, may I ask, are the key interventions taken by your government, and what are the key achievements thus far? Thank you.
Thank you so much. Excellencies of Southeast Asia, Honorable Ministers, Dr. Poonam, Regional Director, WHO Zero, and dear colleagues. Namaste, a very good morning to all of you. I express my deepest gratitude for the honor of being able to address such a crucial topic. I would like to highlight India's efforts relevant to this issue. Honorable Prime Minister Shri Narendra Modi ji has time and again proclaimed India's vision of Antyodaya. Antyodaya meaning reaching the last person in the last mile. Investment in primary health care is the most inclusive, equitable, and cost-effective way to achieve universal health coverage. Majority of government expenditure is now happening in the sector of comprehensive primary health care. Fulfilling the principles of Antyodaya, leaving no one behind, more than 161,000 Ayushman Bharat Health and Wellness Centers, in short ABHWCs, have been established and are transforming the delivery of CPHC, Comprehensive PHC. Excellencies, since the establishment of the first health and wellness centers in 2018, India has implemented significant reforms such as making an expanded range of medicines and diagnostics available, implementing IT-based solutions, and engaging in health promotion and wellness activities. It is worth mentioning that there has been a consistent increase in the flows of funds toward the PHC sector. The increasing trend of expenditure on social security by the Government of India from 5.7% in 2014-15 to 9.3% in 1920 as a share of total health expenditure. And India has remarkably reduced the out-of-pocket expenditure as the per capita spending on the healthcare by India doubled from 2014-15 to 1920. To ensure that essential quality health services are available across the level of care, Indian public health standards have been revised in 2022 to align them with PHC priorities. Quality accreditation of PHC facilities is undertaken under India's flagship National Quality Assurance Standards (NQAS) initiative. As one of the many policy reforms, the Community Health Officer (CHO) cadre has been introduced at primary levels. India's ASHA program is the largest community health worker program globally. Telemedicine platforms have enabled the health system of India to provide medical advice via eSanjeevani, thereby increasing access. The Government of India has shifted the focus from illness to wellness with activities like yoga, cyclathon, walkathon, and Fit India and Eat Right campaigns. India's strong health system relies on a whole of government and whole of society approach. Excellencies, India's leadership in the G20 has emphasized the importance of strengthening national health systems by putting people at the center of preparedness and preparing them to respond effectively. This would help to achieve universal health coverage with the goal of strengthening primary health care and improving essential health services and health systems to pre-pandemic levels. In light of the collaborative spirit, the Heal in India initiative seeks to provide affordable, integrated, and holistic treatment to the world in India. Further, with Heal by India, we have served the world as per Indian philosophy of Vasudhaiva Kutumbakam. The world is one family, bringing the global south to the forefront. Thank you so much.
Thank you very much, Excellency Dr. Bharati. Reaching the last person in the last mile and taking so many different types of experiences. Thank you very much. May I now, with respect, invite His Excellency Mr. Mohammed Naseem. And the question to you, sir, is the FAFU Atoll demonstration site provides an important model for integrating quality NCD and mental health services at the primary care level. Could you please speak about the collaboration with the local stakeholders, the use of technology, and other advances that have been important in this pilot project? Could you also identify 2 or 3 lessons learned during the pilot and how Maldives is incorporating them into the model and your plans to go forward? It's a long question, but I'm sure you're able to answer it. Thank you very much. You know about it. Thank you, sir.
Thank you. Thank you very much, sir. Thank you very much. Maldives have achieved many public health achievements through primary health care. And most recently, the establishment of 178 islands free of leprosy, and before that, the elimination of mother-to-child transmission of HIV and syphilis. However, our current disease burden and mortality rates show a direct correlation to NCDs and NCD-related risk factors. This led to the question, why not apply the primary healthcare model to combating this increasing trend? So we hatched the FAF et al. Model. The PHC model piloted at the FAF et al. Demonstration site is tailored to the needs of the individual and the community rather than promoting the belief that there is something that fits all. The intervening teams are designed and encouraged to be multidisciplinary, with healthcare, non-healthcare professionals and interested locals working collaboratively to ensure that the health and well-being of the community. Instead of the patient coming to the health facility, our healthcare and non-healthcare professionals go to their homes and the communities with positive health messages and interventions. Rather than focusing on just clinical skills and curative measures, HCP focuses on establishing a dialogue with their patients, gaining their trust by utilizing both clinical and non-clinical skills and data from our digital tools. The PHC portal and NCD model developed through DHIS to provide a dashboard for policymakers with stats, numbers and trends. It also measures the effectiveness of our healthcare interventions. We can now monitor the eligible population of FAF et al. And apply the work of the HCPs in real time for instantaneous decision making. Initiating the pilot program at FAF et al. Came with challenges and a lot of lessons. We learned about the professionals within the system with the ability to make or break the program. Those who are resistant to change, those who are keen for data-driven models of care, and those who are ambivalent to progress. Touching base with our teams on a weekly basis, from our digital system and proof of commitment to the program from policymakers did wonders in progressing the pilot into the second and third phases. Our second lesson was the importance of incentivizing those professionals who are dedicated to upskilling themselves and their communities to ensure their health and well-being. We learned the importance of giving these individuals a platform to speak about their interventions, the challenges that they faced, and their creative solutions. It creates an environment of continuous development whilst making these individuals feel supported, appreciated, and even more committed to the task. Most important lessons of all is that the community is invested. The community is compassionate and are keen to promote good health and well-being practices if shown the data, the trends, the actual outcomes of the following good practices. When they learned about these at risk of anxiety and depression, it kick-started a spirit of educating oneself about mental health, brought about a spirit of togetherness and quiet support within the community. This is the purpose of the community-led primary health care. PADS is an environment of compassion, commitment, collaboration, and creative interventions. It is a model designed for the people, supported by the people, and implemented with the people. Thank you.
Thank you very much, sir. May I now come to Nepal and request Excellency Basnet to tell us a little bit about the important policy efforts, including your 2018 Public Health Service Act and the 2019 National Health Policy, which are driving access to basic health services for all citizens in your country. In your recently decentralized context, how is primary healthcare being advanced through engagement with your provincial and local governments, Excellency? Please.
Thank you. Honorable Ministers, Excellencies, Regional Directors, Poonam Ji, distinguished participants, Namaste and very good morning. The Constitution of Nepal mandated access to free basic healthcare services to all citizens, based on which the country has updated policies and strategies. These strategic documents have defined full spectrum of primary healthcare services from health promotion to prevention, treatment, rehabilitation, and palliative care in life cycle approach. Public Health Service Act 2018 ensures the implementation of free basic health service in all three levels of government. And National Health Policy 2019 suggests the guiding principles and priorities for our health system to achieve SDG. Recently, in 2023, government has approved Nepal Health Sector Strategic Plan 2030 and Nepal Health Financing Strategy 2030, based on learning from federalism and COVID-19. These recent strategic documents have translated in practice core principle of strong primary healthcare system and multi-sectoral partnerships at all levels of government in the federal context. The country is reorienting healthcare services as per the geographical distribution and diseases burden. The government is expanding basic healthcare centers at community levels and primary hospitals in municipalities. The federal government is supporting sub-national levels, both technically and financially. The federal government has provided different types of grants to local government for ensuring essential health services. Each level of government has enthusiasm to deliver quality healthcare services to its citizens with financial security. Key programs to reduce health equities, such as health insurance and social health protection schemes, have been implemented nationwide. WHO, including deployment partners, are working at sub-national level to support the health sector. However, the capacity of sub-national governments varies in strengthening quality health service delivery and face many health equities and differences across various SDGs indicators. The country has challenges on maintaining capacities of sub-national governments in health system governance, sustaining key public health achievements, managing health workforce, addressing emerging burden of non-communicable diseases and mental health. Coordination, including health workforce management among sub-national level, needs to be enhanced. Country needs continued support in strengthening capacities of local governments in terms of effective and efficient resources allocation and mobilization for promoting equitable and equality healthcare. we are willing to share and learn country experiences on federalism across health system functions. The member state of WHO across different regions could be learning platforms for health sector prioritize and functions. Thank you very much.
Thank you very much, Excellency, for that important intervention. Next, I move to the country I know best, Sri Lanka. Her Excellency, Dr. Arambipula, can you tell us how the PHC-related reforms based on a shared cluster approach in Sri Lanka, which we read about, how is that enabling Sri Lanka to address and also build back better from the recent economic challenges? Please.
Thank you, Dr. Palithe. My dear colleagues, Excellencies, RD, and other delegates. Ayubowan, wishing you a long life. The Sri Lanka public sector health service divides into line ministry and provincial ministry administratively, and in clinical perspective divides into curative and preventive sector. Just I want to give a brief description about the sector in Sri Lanka. The level of care in the curative sector is divided into primary, secondary, and tertiary care. The preventive sector comprises of vertical programs and medical officer of health, where preventive sector plays a major role as a primary health care providers. We have 354 MOH areas where we have allocated medical officer of health, public health midwives, public health inspectors. So we are able to deliver primary health care service or solution to our public doorstep. And that was the key success and our main strength during COVID mitigation. During the first wave, we have done a lot of work using this sector or this system to deliver a lot of services during COVID management. To be more efficient and effective of the health system in Sri Lanka, Ministry of Health is in the process of implementing the shared care cluster concept, as you asked about it. The shared care system will be a solution for current economic crisis by reducing the bypassing phenomena. As we have well established the structure or the system of primary health care system since decades. Now we are facing economic crisis. Now we have to enhance or strengthen this infrastructure or the system by giving financial hand. So to enhance infrastructure as well as human resource strengthening. So structure is there. Now we are trying how we can help them to go on giving their good service to the public. It is mandatory that care pathways are developed, which will guide the level of care use. These levels of use will enable to establish the shared care cluster concept. As an example, a stroke patient may not need long stay at tertiary and secondary care level, where these patients can be sent to primary care level hospitals for long-term management, with support from the tertiary care hospitals consultants for management through physical visits or telemedicine mode, such as geriatric and palliative care, where we can reduce transportation cost, where we can reduce their unavailability of human hours for working, because one patient goes with another partner from their family. So it's reducing working hours and so economic effect, or as well as patient will get more patient-centric care by those doctors, because number of patients are attending to primary level care is less than when we send them all to the tertiary or secondary. So each patient get more attention from those doctors. Sri Lanka is focusing more on improving utilization patterns at primary care level. The essential services, medicine and medical products are available at the primary care settings, where patients are able to maintain their health and well-being. A shared care cluster system enables the sharing of human resources, infrastructure facilities, laboratory and medical equipment for patient management, which contributes for efficient and effective health system delivery. This emphasized shared care cluster system is the best model during this economic crisis situation to maintain our strong primary healthcare services, which was rendered decades through decades. Thank you so much. Aibo.
Thank you very much, Dr. Angkola. Coming on to Thailand, His Excellency Cholnan, Thailand's achievements in universal health coverage through decades of investment in primary health care are widely recognized, and we all have read and heard about them. Can you share with us now the additional social innovations that you have introduced in your new normal model of PHC services post-COVID-19? Thank you, sir.
Thank you, moderator. Honorable ministers, regional director, and colleague. The COVID has been a test of how health system respond to pandemic, and business as usual is not our option. Here are some social innovations that introduced during pandemic and become our new normal. First, telemedicine. Telemedicine has been fully applied during the pandemic to monitor and provide counseling to COVID patients, as well as maintain treatments for patients with chronic disease. Telemedicine help reduce the exposure risk of health workers. At the same time, it maintains doctor and patient relationship. It also helps reduce overcrowding to hospital. Moreover, hospital staff can see the advantage of using these technologies to monitor resource in the hospitals, such as hospital bed, drugs, equipment, and staff. So this new normal can help to improve services. We now have smart hospital. That public hospitals use digital technology for management and increase hospital quality. Second, patients can pick up medicines from pharmacies nearby their home. This initiative started 4 years ago. So we use this system during the pandemic when patients cannot come to hospital. For now, hospital staff communicated with pharmacies, then patient can pick up medicine from community pharmacies according to doctor's prescription. Patient can reduce the time and travel expense to hospital. Last example, community engagement. During COVID pandemic, communities and village health volunteers help us to control the spreading of disease. They put effort in tracing and monitoring suspected cases in the village and work closely with the doctors and nurses. They now see their roles in promoting health. Many local communities lead health promotion and disease prevention programs by educating people about the symptom of disease and how to make them health. Excellencies, COVID accelerated certain innovations, and these social innovations become a new normal practice. The government sustains these innovations by 30-bar scheme upgrade. Policy as follows. Advancing primary healthcare, which improves access to essential service, including through telemedicine. Advancing district hospital, to ensure smooth referral up and down between primary and secondary care. Advancing digital health, which allows people to access outpatient service at anywhere using citizen ID card. This will speed up the development to electronic medical record and personal health record to increase health literacy and practice excellencies. These social innovations are major game changer for our Thai health system. Thank you.
Thank you very much, Excellency. Very impressive list of innovations that you introduced. Thank you. May I now, with respect, call upon you, Madam Chair, to talk to us about the recently inducted new government of your country has reiterated the priority to strengthen the health sector by proposing an integrated health program. How will this help to provide better health services to your people? Please.
Thank you for the question. DG Dr. Tedros and RD Dr. Punham, Excellencies, Health Ministers, Head Delegation, partners, colleagues, and friends. Timor-Leste has always strongly believed that the path of universal health coverage leads to primary health care. The Director General Dr. Tedros and RD Dr. Singh regularly remind us that primary health care is where the battle for health is won or lost. And in the spirit of the laudable declaration of the Health for All at Alma-Ata and Astana, Timor-Leste has always prioritized a primary healthcare first approach while building its health services. So, how does Timor-Leste demonstrate its commitment towards a PHC-led approach? First, the fundamentals. The right to health is enriched in article of our Constitution, and the health services are free at the points of service delivery. Next, putting our money where our mouth is. Our political commitment towards the PHC is demonstrated in our latest National Health Accounts exercise, which show that over 40% of our health budgets goes towards primary health care. And putting our resources where primary health care is delivery. By exponentially increasing our health workforces, due to which the numbers of doctors in the country has gone from less than 30 to more than 900 in less than 15 years. We have managed to place teams with doctors, nurses, midwife at lowest level of service delivery at every health post, and accomplishing that is difficult in most low and middle income countries. And these teams visit families in their homes when they cannot come to see the doctor or consult a health worker at the health facility. Our commitment to primary health care has been further strengthened in the recently constituted 9th Government Constitutional. We have now appointed a separate DG for primary health care. This new leadership position will further focus our efforts towards
PHC and domiciliary visits. We also launched revitalized integrated health services to drive that will bring together to facility care, outreach care, and doorstep care. This integrated health service program will integrate service provision across primary, secondary, and tertiary care. By linking it with the community, and it will integrate different national programs within our health system. This will be primary vehicle to implement the comprehensive essential service package and ensure holistic preventive, promotive, curative, and rehabilitative care close to where people live. This is a flagship program of the new government in the area of health, and we count on the continuing and trusting support of WHO to implementing these innovative and improve health outcomes for our people. Many thanks. Obrigada, Barak.
Thank you very much, Dr. Elias. Excellency, Mr. Cho Hui Chol, your country's PHC strategy was recently updated from 2021 to 2025. What are the key focus areas that you have introduced to further develop the PHC-oriented system in your country, including, for example, the use of technology and a strengthened household doctor system? Can you share some information on that, please?
푸남 지역소장 선생, 위장 선생과 위장 선생, 여러 대표 선생, 안녕하십니까? 상기 질문에 대한 대답을 하겠습니다. 최근 조선민주주의공화국은 1차 의료봉사 전략 2021-2025년을 갱신하고 이행하고 있습니다. 갱신된 1차 의료봉사 전략의 기본은 이미 실시되고 있는 의사 담당 교육제를 더욱 강화하고 예방 원식 의료봉사를 잘하여 담당 의사들이 가정세대들과 노당 현장들에 들어가 주민들이 각종 질병들에 대한 예방 대책의 세고 건강관리 사업을 체계적으로 함으로써 병 걸림률을 공정 낮춘 것을 골자하고 있습니다. 현재 먼거리 의료봉사 체계를 전국이 말단 치료 예방 단위인 비병원, 비진료소들에까지 확대 도입함으로써 1차 개선에서의 전염성 질병 감시, 먼거리 질병 진단 지원, 의학 정보 보급, 보건 정보 관리를 더 개선해 나가고 있습니다. 조선민주주의공화국 국민의장 김정은 동지께서는 인민보건의 발전을 견인하는 기본 동력은 인지와 의학 과학기술이라고 말씀하셨습니다. 우리나라에서는 다른 모든 사업에서와 마찬가지로 과학기술을 틀어지고 의과의 보건사업을 발전시켜 나가고 있으며 이것은 1차 의료봉사 전략의 이행에서도 예로 되지 않습니다. 우리는 호담당 의사 재교육 강습 재강을 변화 발전하는 보건 실질적 요구와 세계적 수준에 상호하게 갱신할 뿐 아니라 그에 대한 강습을 모든 도시 군들에서 이행하도록 함으로써 1차 의료봉사의 직접적 담당자들인 호담당 의사들이 높은 과학기술 지식을 소유하고 외기차의 책임성과 역할을 더욱 높여나가도록 하고 있습니다. 우리 정부는 세계적인 대유행 상황에 대처하여 1차 개선이 필수 의약품 및 의료기구 목록, 필수 의료봉사 목록을 갱신하는 데 맞게 그 실행을 물질적으로 담보하기 위하여 매양산 의료기구 공장을 비롯한 제약공장들에서 질적 의료기구와 의약품들을 대다수로 생산하여 안정적으로 보장하게 하는 사업을 힘있게 내밀고 있습니다. 우리 공화국 정부는 앞으로도 사회주의 보건의 혜택이 우리 민의 피부에 가닿도록 하기 위하여 자기 용의롭고 책임적인 임무를 언제나 충실히 집행할 것이며 전반적 의료 봉사와 보건 관련 유엔 지속 개발 목표 달성에도 적극 기여할 것입니다. 감사합니다.
Thank you, Chair, Vice Chair, and Moderator. Good morning to all honorable ministers, Madam Mardi, and dear delegates. Recently, the DPRK government updated the national strategy of PHC 2021 to 2025 and is implementing it. Further strengthening the existing household doctor system and improving the current preventive healthcare services are the key points of the updated PHC strategy to lower the prevalence rate as much as possible. The household doctors used to regularly visit the dwelling houses and workplaces and take preventive measures to protect the residents from different disease, and they should bear a higher sense of responsibility for the residents they are in charge. This is consistent with the nature of socialist health system, with the noble aim of saving lives of people and in line with the people-centered health that WHO has been advocating recently. The National Telemedicine Network has been extended to the re-hospital and re-polyclinics, which are the grassroots medical settings. Thus, the surveillance and management of communicable disease, teleconsultation for diagnosis of disease, dissemination of health-related knowledge and information have been strengthened at the primary level as well. Comrade Kim Jong-un, President of the State Affairs of DPR Korea, said that the main driving force pushing the development of the public health is skilled doctors and improved medical science and technology. The DPRK government is developing the work of public health by holding high science and technology as well as in the other fields. And the implementation of the national strategy of PHC is not an exception. The reorientation and in-service training materials for household doctors are regularly updated according to the demands of evolving medical practices and global standards. And the trainings covers all doctors in the country. Through these activities, the household doctors directly in charge of the PHC acquaint themselves with the novel knowledge of medical scientific technology and bear higher sense of responsibility. The COVID-19 crisis we had faced in May 2022 and the 90 days of fight to finally tame it has proved and underlined the important role of PHC. In response to the eventual global pandemic, we updated lists of the essential medicines, medical apparatus, and essential medical services needed in primary level, and we are pushing ahead the massive production of high-quality medical appliances and medicines in the medical equipment and pharmaceutical factories, including renovated Myeongsan Medical Appliances Factory, in order to ensure the sustainable supply of medical supplies in the country. The DPRK government will be faithful to its honorable and responsible duties to ensure our people to feel themselves the benefits of the socialist public health and will contribute to the realization of UHC and health-related SDGs worldwide. Thank you.
Thank you. Thank you. Thank you very much. Thank you very much, Mr. Choi. Honorable Pemba Wanchik from Bhutan, can we have you next? The question to you is, what are some of the key lessons for you and for us from your piloting the Service with Care and Compassion initiative that you started in Bhutan? And what are the opportunities and challenges that you face for scaling it up nationally? Thank you.
Thank you for the question. And thank you, Professor, for the very wonderful presentation. Excellencies, Head of Delegations, Madam RD, ladies and gentlemen, non-communicable diseases are the leading cause of morbidity and mortality worldwide. In Bhutan, 69% of all deaths are contributed by NCDs, majority of which are preventable and are therefore premature deaths. Thus, NCDs pose health system challenges, including the sustainability of healthcare services to the people. Overarching consequences of NCDs culminated into Bhutan's adoption of national policy and strategy framework on the prevention and control of NCDs in 2009 and implementation of a multi-sectoral National Action Plan 2016 to 2020. As a part of country's intensification efforts, Bhutan was among the first countries in the WHO Southeast Asia region to adopt and integrate PEN in the primary healthcare system in 2010. This initiative was reinforced in 2019 through adaptation of Penhart's package, as now we call it Service with Care and Compassion Initiative, SCCI. The success in piloting in 4 districts led to scale up, and today 14 out of 20 districts implement Penharts in Bhutan. The objectives of SCCI are A, to ensure timely diagnosis and continuum of care, B, to adopt standard procedures and responsibilities, and C, to encourage innovation at the district level based on local contexts to produce better patient outcomes. This model is known as 7R: robust team building, reach out to the housebound services, refill of medicines, recall and reminders, responsive referrals, reliable and people-centered laboratory diagnosis, and real-time monitoring and supportive supervision. And 3 C's: comprehensive, collaborative, and continuum of care. It is operated through a 3-way partnership comprising of Ministry of Health, district health authorities, and medical college, with the role of leadership, implementation, and clinical support, respectively. On the strengths and opportunities, a Penhart's baseline study 2020 reported a positive impact with lowering proportion of patients with a treatment gap and a higher proportion of patients were retained for care. Similar rapid assessment in 2022 shows the overall improvement in availability of the essential medicines for hypertension, diabetes, and CRDs, especially at the primary healthcare level. The health facilities could request drugs from the nearest higher level health facility using Form 3 for refills. 85% of health facilities established reminder systems for patients who faltered to receive their medications on time, or those who did not show up for their monthly refill, using methods such as phone calls and social media. Health workers also engaged community members such as patient families, neighbors, and village health workers to facilitate homebound care. In recognition of the progress of NCD efforts, Bhutan received the 2022 UN Interagency Task Force and the WHO Special Program on Primary Health Care Award. However, challenges are noted while implementing the NCD policies and plans. These include broadly financial resources, shortage of human resources, weak coordination among the stakeholders. The countdown for SDGs is getting closer. Ambitious targets such as 50,000 people to be put on hypertension and diabetes protocol by 2025 call for even greater attention and actions on scale and intensity. I'm sure that this August gathering will deliberate and provide greater insights and roadmap towards achieving these ambitious targets. We are grateful to WHO for technical support and look forward for continued support as we embark on more ambitious targets. I thank you.
Thank you very much, Mr. Dr. Munira, your national PHC integration, which aims to provide quality PHC care for 270 million people with 300,000 primary care units, is a very bold initiative and taken by your country. Can you share with us some lessons that we can learn regarding why this was needed and what are the key innovations that you are introducing to support this program. Thank you.
Thank you, Mr. Moderator. Your Excellencies, distinguished ladies and gentlemen, allow me to address this question by taking the leaders to recall our state commitments at the United Nations high-level meeting on universal health coverage in New York in September 2023, just a month ago, emphasizing that primary healthcare services as a cornerstone to accelerate progress towards achieving universal health coverage. Indonesia is currently transforming its national health system in order to ensure equitable, accessible, and high-quality healthcare services, as well as fulfilling the community rights for adequate healthcare services for our 270 million Indonesians. For many years, Indonesia has put much emphasis on curative care, which not only is this strenuous on our economy, but also can be considered as too little, too late. Looking at countries that have efficiently achieved UHC by comparing their health expenditure per capita to their universal healthcare coverage or their life expectancy, as presented by Professor Ann Mills just now, we can see that investing in primary healthcare is the way to go, especially for a middle-income country like Indonesia, where the budget is not unlimited, and yet there are many competing needs for our total budget. This is also in line with the Sustainable Development Goals, Goal 3, which is ensuring healthy lives and promoting well-being for all at all ages. So the Ministry of Health views that our mandate is not to cure sick people, but to ensure healthy lives, and primary health care is central to ensuring this. Therefore, in Indonesia's health transformation system, the first pillar of this initiative is the transformation of primary health care, which focuses on strengthening promotive and preventive services in order to create healthier populations, enhancing screening tests, and preventive services in order to create improving the capacity of primary healthcare services. There are 3 focus areas within this transformation in the primary healthcare, which are 1, integrating primary healthcare services based on a life cycle approach. The second is bringing healthcare closer to the communities. Our primary health centers are around 10,000 centers, and for a population of 270 million, obviously this is not sufficient. Therefore, we are building on existing community-based health posts that are available around the country. And this is empowering health cadres that are already running the services at variety of various different focuses. So to enable this, Indonesia has issued a new ministerial regulation on health that encourages a standardization of services in the community health centers, our puskesmases, our sub-health centers, our pustus or puskesmas pembantu, and integrated health posts or our posyandu. Key innovations in the transformation of primary healthcare services include investments toward health, including standardized healthcare, health promotive and preventive approach, strengthening of human resources for health, which includes the health cadres, and improving healthcare facilities. Notably, Indonesia has conducted a standardized capacity building for community health workers, in which the Ministry of Health has been collaborating with other ministries and agencies by developing the 25 core competencies for health cadres. Through this, we hope that 3 million cadres will be able to provide comprehensive education to the community. Additionally, we have standardized services through the integration of primary health care, and Indonesia has revitalized more than 10,000 community health centers at the district level, more than 83,000 at the village level, and over 330,000 integrated health posts at the hamlet level, which would lead to more accessible and affordable healthcare services for the community. Furthermore, in 2022, the Ministry of Health initiated a pilot project for the integration of primary healthcare services in 9 provinces. The result of this pilot project were promising, with increased coverage and enhanced services in Puskesmases, Pustus, and Poshandus, as well as home visits. To scale up and expand the nationwide implementation of our integrated primary healthcare services, we've officially launched this initiative in August 2023. This launch is intended to build momentum for the national implementation of the integrated primary healthcare service and to highlight our commitment from stakeholders and district governments to advocate for and disseminate these practices in every province, every district, city, and community health centers throughout Indonesia. Thank you.
Thank you. Excellencies and distinguished delegates, thank you very much for all those rich ideas, such a variety of rich ideas on a wide spectrum of PHC elements, which I think all of us can learn from, can draw from. Now, this brings us to the end of the first round of our presentations. And it's time for a healthy break, WHO style. Yeah, we enjoy that every time we attend these meetings, we can learn something. Can I give this information before we get into the healthy break as such? This will be a short activity to the song One World, One Region, One Future. And while this is going on, tea will be served individually at each of us. This. And after the Energizer, we will carry on with the second round of interventions. I think if you want to take a restroom break during this, you might like to do that. And our colleagues will help you with that. So in that case, shall we start the break, Dr. Mek? Yeah. Yeah. One little. Please be seated, but have a little space in between so that the movement will be easier. And, please relax and enjoy it. Yeah, please. Okay, thank you.
Championing primary healthcare together.
Whoa.
Being the we are championing primary healthcare together.
One world, one vision, one future.
One health, one hope, one heart.
In this Southeast Asia region, we are each other companion for the future of billions. Let's work together and leave no one behind. 1+1 together, leave no one behind. This long journey, we are friends. Let's work together and leave no one behind. A World Health Organization, a stronger foundation. World Health Organization, evidence and action. Me and you, two and two, one future. One world, one region, one future. One health, one hope, one heart. One world, one region, one future. One health, one hope, one heart.
Thank you very much. Excellent. It really does energize, doesn't it? It really energizes you. Thank you very much. Yeah, very nice. After that, listening to all the speeches, it suddenly gives you a lot of new energy to go to the next round also.
For those wanting to go to the washrooms also.
Yeah. Yeah, we can take a restroom break for a few minutes if you like, yeah. And then reconvene in about 4 or 5 minutes.
Yes, esteemed guests, kindly take your seats for us to proceed to the second round. Thank you very much. Distinguished delegates, I kindly ask you to return to the hall. We need to continue, please, with the second round of the Ministerial Roundtable.
Yeah, but wait, just.
Dr. Palita, please, you can start. Distinguished guests, distinguished delegates, ladies and gentlemen, Madam Mardi, it's good to have you back, all of you. Dr. Palita, over to you, please.
Thank you very much. Excellencies, distinguished representatives, Madam Regional Director, welcome all of you back. Having been energized, let us now continue with the second round of our ministerial roundtable. This round, as I mentioned earlier, I will proceed in the reverse order. For the second round, you will have less time. And I kindly request you to keep your intervention to 3 minutes, if you can. First question this time is to Indonesia, to Dr. Sharifa Munira. How have promotive and preventive initiatives been integrated into the overall strategy for enhancing PHC in Indonesia? And what challenges and barriers have you encountered while doing so, when implementing these strategies? Please.
Thank you, Dr. Palita. Our current promotive and preventive services in the primary healthcare in Indonesia consists of 3 fundamental initiatives to strengthen disease prevention. This includes routine immunization of 14 types of antigens. This is an expansion of our previous 11 antigens, which now adds PCV, rotavirus, and HPV vaccines. Second is 14 screenings of priority diseases. This is a strengthening and expansion of the previous screening program. Third is a maternal and child healthcare services, which include monitoring children's growth and development at Posyandu with standardized anthropometric tools, antenatal care, pregnancy checkups, which include 2 ultrasound examinations by OBGYN specialists in the 1st and 3rd trimesters. Through integrated primary healthcare, we strive to scale up these services into more basic healthcare levels, the village level Pustu and hamlet level Posyandu, as well as affiliated private clinics and home visits. And these are linked to performance-based fundings as a complement of our capitation system at the primary level. And I believe perhaps from the slide that Professor Ann Mills showed us, this might be considered an adjusted capitation system. However, geographical and resource capacity diversity nationwide poses a challenge in Indonesia. To address this challenge, we are needing to make more efforts to synchronize regulations across programs and sectors, secure commitment and support from local governments, ensure the availability of standard human services, facilities, and infrastructures in primary healthcare, and enhance the recording and reporting system through digitization. These challenges have encouraged Indonesia to put more efforts into the integration of primary healthcare initiative. Thank you.
Thank you very much, Dr. Sharifa. Thank you very much. May I now come to Bhutan, Honorable Pemba? The question I'm going to ask you is, what are some of the key areas of service delivery, reorganization that Bhutan has undertaken during COVID-19 pandemic to support UHC? Please.
Thank you, Dr. Palita, for your question. Excellencies, ladies and gentlemen, the COVID-19 pandemic has put the health systems of many countries to a breaking point. It has also forced nations across the globe to make significant changes and adjustments to the delivery of essential health services, particularly when there is widespread community transmission. Nonetheless, Bhutan is pleased to share with the forum today that despite scarce resources and a nascent health system, Bhutan has managed to successfully contain the pandemic by making best use of the evolving science and evidence around the pandemic, and by being extremely cautious and proactive in our COVID-19 containment efforts. We have also managed to navigate around the challenges posed by the pandemic in ensuring the continuous and seamless delivery of essential health services. In early 2020, as a risk mitigation effort, Bhutan initiated the flu clinic system for treating flu-like illnesses with a goal to safeguard mainstream health facilities from COVID-19. The flu clinics were later equipped with tuberculosis diagnosis facilities to enhance the detection of TB cases. With a goal to minimize the incidences of flu-like illnesses and to help narrow down our focus on COVID-19, seasonal influenza vaccination was rolled out across the country. To maintain our efforts towards eliminating cervical cancer, and besides the HPV vaccination programs for girls, Bhutan rolled out HPV vaccination for boys by inoculating 97% of grade 6 or 12-year-olds in September 2020. To ensure continuous services for the elderly and those with comorbidities, medicine refill services were initiated across major towns, whereby medicines were delivered at zonal hotspots, which helped limit the movement of people and minimize the risks of virus transmission. Emergency departments were isolated from mainstream structures, and triage systems were set up in major health facilities with RT-PCR and rapid antigen testing facilities to ensure that the hospitals are not being compromised by preventing the spread of infection in the hospitals. A separate health hotline for emergency, routine, and elderly health services manned by doctors and experienced clinicians were established to minimize the risks of COVID-19 transmission. In addition, we have prioritized deployment of specialists in rural and peripheral areas and COVID-19 high-risk areas to take health services closer to the communities and limit the excessive movement of people. Excellencies, ladies and gentlemen, in such unprecedented and unpredictable times, Bhutan found our answers in unique but simple strategies. By combining the powers of science and logic, along with exceptional solidarity from all sections of our society, we managed to forge an exceptional response to the pandemic. We will continue to be guided by science, facts, and logic in designing our future strategies to ensure the uninterrupted delivery of essential health services to the people of Bhutan. Last but not least, even in the midst of pandemic, we have ensured uninterrupted provision of essential health services. Thank you.
Thank you, Mr. Member. The powers of science and logic. Yes, thank you. Democratic Socialist Republic of Korea. Excellency Cho Hee, please let us hear about the main characteristics of your health system in DPRK right now, because this will be interesting to most of us, and there may be lessons for all of us in other countries also. Please.
시간 단축을 위해서 나의 대리인이 대신하겠습니다.
So in order to shorten the time, allow me to speak on answer on behalf of my ambassador. First characteristic is the universal free medical care. In the DPR Korea, where the human being is regarded as the most valuable, the universal free medical care has been introduced in 1953 at the most difficult war time when the destiny of the nation was at stake. And it has now a history of 70 years. In the DPR Korea, the public health system is complete and universal free medical care for all people, irrespective of their gender, age, and occupation. and has its basis guaranteed by the state legally, systematically, financially, and materially. The government, in order to strengthen its primary healthcare system in the DPR Korea, maintains the unified and integrated national guidance system for health services with strict monitoring and supervision of the content and quality of the primary healthcare services throughout the country. Furthermore, the network of the reorientation and in-service trainings for healthcare workers is functioning regularly to improve the skills of doctors and nurses. Second characteristics is the preventive medicine policy. The great President Kim Il-sung, founder of the DPR Korea, taught that the main essence of socialist health system is the preventive medicine. Do not treat the people relying only on drugs once they get sick, but give high priority to taking preventive measures in advance and prevent people from getting disease. Third characteristics is the household doctor system. The DPR Korea has established a tightly interlinked primary health care network comprising of 1,700 county and hospitals and 6,200 Ri-dong clinics throughout the country to provide the primary, preventive, and curative healthcare services on the basis of a household doctor system. One household doctor is in charge of 130 families on average. Fourth characteristics is the establishment of unified guidance system in case of pandemic, where all the state organs, social entities, whole country and all people are mobilized and move in a united way in line with the unified guidance of the government. In January 2020, when the COVID-19 broke out in the neighboring country, and even before WHO declares public health emergency of international concern, the DPRK government established the powerful state emergency anti-epidemic headquarters comprised of not only the Ministry of Public Health, but also all government organs, people's committees, social entities, public security organizations, and other establishments, and formed a well-structured emergency anti-epidemic network down to the lowest level, such as Ri and county, in order to cut off the channel of inflow of COVID-19 and control it in a short span of time in case of its outbreak. Thanks to such robust and strong primary healthcare system, we could successfully overcome the national public health crisis due to COVID-19 virus inflow in the country last year in a short span of time. Thank you very much.
Thank you, Mr. Thank you very much. Madam Chair, Dr. Elia, would you like to respond to this question? We are all very well aware that access to care steadily keeps improving in Timor-Leste.
Thank you for the
What
question.
steps are you taking, in addition to access to care, to improve the quality of care of your health services? Please.
Thank you for the questions. Globally, the quality of the health services has become even more important than access to health services. For improving health and well-being, Timor-Leste is no different. Even as we improve access, our focus on quality must now improve. In the 20 years since restoration of independence, we have increased access by rapidly increasing the number of health workers, especially doctors. We have also increased the health budgets to build more health facilities, procure more drugs, diagnostic and devise and stabilize a health system information for primary health care. While these measures have filled the quantity of gap, we realize that our health facility will not be natural first choice for our people unless we also address the quality of gap. So we prioritize the quantity of improvement. Let me give you some examples. With WHO support, we are launching simulation and skill centers in all secondary and tertiary care hospitals so that our health workers can improve the hands-on experience in dealing competently with the patients. Large training programs for skilling up health workers for mother and child sets the point of care quality improvement, communicable, non-communicable, emergency, and intensive care are rolled out with support from WHO and the partners. We are looking to improve the quality of medicines and medical products by strengthening our national regulatory agency in improving our system for maintenance of biomedical equipment. The new digital health system and HMISC strategy we are finalizing has strong elements of quality control as has for our national laboratory. And we are now in the final stage of endorsing quality standards for both our public and private health facility. Implementing and adhering to those standards will ensure that our people have access to safe, quality assured, timely, and affordable care. Improving quality and trust is not easy. It takes time. It takes hard work. And I know I can count on WHO for high quality support in this journey. I thank you.
Thank you very much. His Excellency Sholnan, please tell us how Thailand organized the family care team to ensure quality, people-centered primary healthcare across the country. And very interesting for us to learn that. Please.
Thank you for your question, moderator. Honorable ministers, regional directors, and colleagues. Our Primary Health System Act was passed in the 2019. It aims to increase equitable access to a comprehensive range of quality health service based on life cost approach to the function of family care team. A family care team consists of family doctor from district hospital, health workers at health center, and village health volunteer. This team is responsible for 10,000 population in catchment area. At community level, village health volunteer play active roles in supporting health promotion, public health service, health service delivery, consumer protection, and promoting health knowledge. At health center, health workers provide basic service including screening, disease surveillance, and health promotion. At district hospital, family doctor provides healthcare service. We aim to establish more than 6,000 teams nationwide. Family care team is an innovation of Thailand health systems, development in response to rapid demographic transition, emerging disease, and social change. To maintain the healthcare worker in the system, Thailand has fully applied World Health Organization guidelines on retention since 1970. This includes mandatory rural service to understand primary healthcare functions, financial incentive, and non-financial incentives. The non-financial incentives are social recognition, career advancement and promotions, and safe workplace. These interventions have proven effective on retention Excellencies, health and care workers are key factor to make primary healthcare functioning. Thank you.
Thank you very much, Excellency Sholnan. Thank you very much. Excellency Dr. Sita, how can Sri Lanka achieve UHC through the PH reforms that you have already introduced? And how do you plan to ensure people's health excellence, quality of services?
Thank you, Dr.
Thank you.
Palitha.
Thank you.
Chair, Excellencies, Sri Lanka is in the process of strengthening the primary healthcare service with WHO 6 building blocks. Everyone is very familiar with those: governance, service delivery, healthcare workforce, essential medical and medical products, information technology, and sustainable health financing with the aim of achieving universal healthcare. Although there are 6 building blocks, Sri Lanka has special concerns on sustainable health financing towards primary healthcare services, investment on healthcare workforce, and on governance. All these interventions focus on life course approaches to individuals and will include curative, preventive, rehabilitative, and promotive services which aim to get quality and safe healthcare services at the primary care level without any financial hardship in an equal and equitable manner. So we can understand financial stability is not the key point to achieve universal healthcare. At this moment, European countries or developed countries are struggling with universal healthcare service because of lack of human resources. They are triggering that pulling factors just to get human resource from our countries. Why? They are struggling to achieve their universal health coverage. So just check about their queue for the surgeries. It doesn't mean so financial stability will resolve this problem. We have to have a lot of other factors, the human resource happiness, that workforce happiness, enhancement, and other things like infrastructure of primary healthcare like Sri Lanka. We have a structure. Yes, we are struggling with economic crisis, but we have the basic structure to achieve this goal. So these reforms include digitalization of primary healthcare, where we are trying to enforce care services for better data flow and for planning of future health services, and monitoring and evaluation of existing programs and management of overall health service delivery. Medical humanities should be part the parcel of the service delivery for ethical concerns, and to ensure empathy and sympathy that address the people's heart and their concerns. Further, Sri Lanka will establish cluster management system to deliver patient-centered, safe primary care. It defines as having an apex hospital, which are base hospital and above hospitals that will link with the other primary medical care institutions within that cluster. Family medical clinics approach at the primary care settings will be supervised by a specialist family physician, strengthening the accidents and emergency services supervised by specialist in emergency medicine physicians, elderly and disability care services, mental health services, eye and ENT care services, special need child care services, integration of digital health and telemedicine are the key areas that Ministry of Health Sri Lanka is focusing and prioritizing at the primary care level. Further, specialist family physicians will be placed at the apex hospitals, which are base hospital and above hospitals. And these specialist family physicians will oversee, supervise, and guide the family medical clinics and its staff at the primary medical care institutions, while conducting the family medical clinic and doing overseeing, supervising, and guidance of staff at the family medical clinic at Apex Hospital. In coming years, specialist family physicians will be placed to all the Apex Hospital and to be increased the cadre, and diploma in family medical officers to be placed at the lower level of primary medical care institutions, which are divisional hospital and primary medical care unit. Similar approaches will be followed for emergency care and other specialties for integrated care provision and different level of care, which are primary, secondary, and tertiary care levels. Finally, Sri Lanka will adopt the above mentioned strategies at the primary health care level in order to achieve universal health care and sustainable, safe, quality health care services of people Sri Lanka. And social health protection also we can't forget. So just social health protection is the other part of the universal health care, where we can strengthen social health protection, we will able to achieve universal health care. Thank you.
Thank you very much, Dr. Yeah, very interesting. Thank you. Excellency, Mr. Basnet from Nepal. Sir, non-communicable diseases and mental health are growing challenges for the health sector in your country. What are the country initiatives towards addressing NCDs and promoting mental health in Nepal? Thank you.
Thank you, Chair, Excellencies. The government of Nepal is implementing the multi-sectoral action plan on NCD prevention and control 2022 to 2025 and National Mental Health Strategy and Action Plan 2020. In 2022, Nepal has become the second country globally to implement the SHARE initiative for alcohol control. We are happy to report that Nepal banned alcohol advertisement in February 2023 through the Supreme Court order, following which alcohol advertising in newspapers has been eliminated. Nepal has taken progressive legislative and programmatic steps in tobacco control. This has resulted in gradual reduction of prevalence of tobacco use in the population. We are working on reducing the industrially produced trans fatty acid to meet the elimination commitments of the country. The government is working with multi-stakeholders for suicide prevention and has operated National Suicide Prevention Helpline. We are also taking steps to reduce access to hazardous pesticide to reduce suicide fatalities. Strengthening access to management of NCDs and mental health services at primary healthcare is a top priority to ensure basic services for common NCDs and mental health conditions. Capacity building of primary health workers has been further enabled through special support since 2021 as WHO focused country for NCD and mental health initiatives. NCD Care Deliver Learning Laboratory has been created in one of the districts using hypertension care as a stressor condition. Psychiatric services are being strengthened, linking and here from the frontline health facilities to district hospitals. Ministry is working on childhood cancer control program. HPV vaccine has been initiated in selected hospitals in 2023. We are working on procurement of vaccine through Gavi. The country is one of the The country is on the initiative, every municipality is a healthy municipality and every school a health promoting school. We recently celebrated World Mental Health Day in presence of Prime Minister and acknowledged health workers working in the area of mental health, which shows the strong political commitment for mental health. There are many more to work on and to accomplish in the area of NCD control and mental health, for which we need strong support from WHO and other partners for strengthening the health system. Thank you.
Thank you, Excellency. Excellency Nasim, can I ask you this question? It's a long question again. A commonly held shared challenge to strengthening primary healthcare orientation of health systems, we know, is a dissonance that exists between financial and commercial interests and trade sectors. Could you identify a notable initiative that Maldives has undertaken in the recent past to address this issue? Also, are there any further initiatives that you in Maldives are planning to increase the collaboration and increase understanding between the financial and the health sectors? I'd like to throw some light on that. Thank you.
Thank you.
Thank you very
Chair.
much.
Thank you, Pastor. There is a common belief that spending more on health results in positive health outcomes. Almost 12% of Maldivian GDP is dedicated to health expenditure. While the government spends 22% of its budget on health, 11% is for service delivery, 11% is dedicated to social health services, social health insurance. Reports indicate that pharmacy reimbursements on drugs increased annually by 27% in the past years, resulting in 32% of health budget being dedicated to pharmaceuticals. Less than 2% is spent on preventive health. So this points to a misallocation of resources with high expenditure on curative services and inadequate financing to disease prevention and health promotion. Our current disease burden indicates that the financing strategy is ineffective in reducing healthcare costs as well as improving health outcomes. In Maldives, NCDs contribute 78% of the total disease burden, is a major cause of morbidity and mortality. Following the WHO modeling study on PHC investments, we conducted a PHC investment case of our own from 2021 to 2022. The primary reason was to create a case study that made the need for primary healthcare financing comprehensible and attractive to financial institutions. Additionally, the document can be used to build capacities of health service professionals, financial sector, and community service groups in preparing the health budget focused to the very needs and requirements of the communities. The digital NCD module developed in collaboration with WHO for FAF et al. Program monitors risk factors, health status, health habits, and showcases changes to the trends based on interventions implemented in island communities. It gives us accurate data in real time, coupled with associated policy and program costs, such as media campaigns, and health systems costs, such as the human resource required for multidisciplinary PHC teams. The module indicates early health impacts can already be observed in a period of 6 to 12 months for certain NCDs like CVDs and cancers. The PHC investment case also shows that the largest gains and returns on investment come from risk factor prevention, indicating for every $1 invested in prevention leads to a cumulative gain of $15, which is equivalent to 15 rupiah, which is equivalent to $1. This is especially visible in cancer prevention statistics. The onus of ensuring health and well-being of our society does not exist in the health sector alone. As it has been reiterated during numerous WHAs and UNGA's countries must adopt the ideology health in all politics, all policies, from the very top to grassroots levels. Nationally, there are various mechanisms already in place where health, trade, and finance ministries are represented, like the Tobacco Control Board and the National Trade Facilitation Committees. These mechanisms not only result in better advocacy and implementation of health policies, but also create better trust, goodwill, and optimal resource utilization between sectors through better dialogue and collaboration. To conclude, primary healthcare is the foundation for healthier individuals and a better world. It is our collective responsibility to embrace transformational shifts and allocate proper finances and resources to harness the power of primary healthcare and achieve health for all. Thank you. Thank you very much.
Thank you, Excellency. Her Excellency, Dr. Bharti. In India, 161,000 Ayushman Bharat Health and Wellness Centers have been operationalized to deliver comprehensive primary healthcare services. What are the key priorities in moving forward that you have identified? Also, a word about how you in India see the Ayushman Bharat Health and Wellness Centers impacting the services that you provide. Please.
Thank you. Thank you, Palita ji. Thank you so much. Colleagues, fulfilling the Honorable Prime Minister Narendra Modi ji's vision of Antyodaya, leaving no one behind, Ayushman Bharat Health and Wellness Centers are transforming the delivery of comprehensive primary healthcare services, which are universally free and provide to all age groups from birth to death through a continuum of care approach. The key enablers for India to deliver comprehensive primary healthcare services and expand at this scale have been the availability of a skilled workforce, well-equipped in terms of training, and the availability of medicines and integrated supply chain. Digital health ecosystem, community mobilization, and health promotion have been key enablers to all service delivery interventions. While HWCs are already ensuring the services closer to community, the last mile reach approach is being repeated through outreach activities and engagement of referral transport for hard to reach and far-flung areas. Through the umbrella approach to Ayushman Bharat, Government of India has also launched the world's largest health insurance scheme, Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, providing a cover of rupees 500,000 to beneficiaries' family in a cashless manner for tertiary treatment, thus protecting the family from financial shock. We'll still believe that we have a long way to go and we are focusing on our key priorities with HWCs, services of maternal and child health, nutrition and non-communicable diseases are reaching the last mile. ABHWCs are now gearing up to be able to address the existing gaps in specific areas of care, that is mental health, elderly care, and palliative care. Excellencies, quality accreditation of all facilities would also ensure that the facilities at this level are meeting the standards under the country's flagship National Quality Assurance Standard Initiative. Special focus on maternal and newborn care and special quality standards have been developed for maternal OTs, labor rooms, and newborn and child services. That is in Suman, Laksh. These are some good initiatives. Muskan. Patient safety tool has been developed for self-assessment by facilities to calculate their score and take necessary corrective actions. Facilities are regularly assessed on parameters related to hygiene, swachhata, and incentivized for good performance under the Kaya Kalp initiative. Ayushman Bharat Digital Mission will aim at creating a comprehensive digital health ecosystem and investments towards standard-based digital health transformation. The convergence of efforts will amplify the voice of Global South. Improved availability, access, and utilization will contribute to equitable population health outcomes. Provision of primary health care with particular focus on vulnerable and marginalized group will increase responsiveness and conclusiveness. In coming to the impact, HWCs lead to increase access to care with an assurance that services are available free of cost and closer to the community. It is leading to improved population coverage, reduced out-of-pocket expenditure, mitigation of risk factors, and decongestion of higher level facilities, thus improving quality of care at all levels. Thank you so much. Thank you.
Thank you very much. Last but not the least, by any means, Excellency Malik, what is the role of healthy city initiatives in your country in addressing urban primary health care? And how do these initiatives contribute to the enhancement of primary health care in Bangladesh in general?
Thank you for the question, important question. Honorable ministers and delegates, a healthy city is characterized by strong leadership, active community participation, a supportive environment, and accessible healthcare services, with a focus on preventive and health promotion. The concept emphasizes a holistic approach to health, encompassing not only the absence of disease, but also the overall well-being of its citizens. So in line with that, we have taken certain actions, which I will just say in few words. To promote health and well-being at urban settings, the City Corporation and the Health Ministry jointly developed a multi-sectoral platform with stakeholders from both health and non-health sectors, including public health departments, the Ministry of Home Affairs, the Ministry of Social Affairs, the private sector, NGOs. And there are also other actors who are also contributing to this healthy city idea. The City Corporation currently provides various maternal, child, and reproductive health services, vaccination, school health programs, also, and at the primary healthcare facilities. Ministry of Health and Family Welfare promotes 37 government outdoor dispensaries at the moment, which is also, I think, inadequate for Bangladesh. Providing primary healthcare services across 8 city corporations and 2 municipalities. Ministry of Social Affairs provides services to homeless people with food, shelter, and treatments. Ministry of Home Affairs rehabilitates drug addicts populations with treatment and counseling. Private sector also plays a significant role in providing healthcare services in urban areas, including prevention and treatment for the population. People go to big hospitals for normal ailments in the city, which is a burden for the hospitals. So we are trying to reduce that. So in the cities also, we have got more respiratory disease compared to the urban areas due to this pollution. This pollution from the building construction, from the vehicles, and from all other areas. Even there is sound pollution in the cities also. Considering the high prevalence of non-communicable disease in Bangladesh, under this Healthy City initiative, the Ministry of Health and Family Welfare, with support from WHO, supporting a large city named Khulna City Corporation, is in expanding the primary health care services to prevent as well as detect, control, manage and refer prevalent diseases like hypertension, diabetes, mental health conditions on a pilot scheme basis. Based on these initiatives, government initiatives experience, our government will scale up the model to other cities of the countries. Approximately 27 to 30% of the population in Bangladesh resides in urban areas. And this urban population continues to grow each year, placing a growing burden on the urban healthcare system. Recognizing the need to strengthen urban primary health services, the National Urban Health Strategy 2020 has been developed to address the healthcare needs of urban dwellers. So in days to come, we will also promote more primary healthcare services in the urban areas in the expanded form. And that has been kept in our next sector programs, where we have kept provision for a new operational plan only to look after the urban healthcare services, which at the moment is not that strong, unlike in the rural areas as the community clinic. So we will be constructing new clinics and also refurbish the old ones in order to cater to the need of the people. Thank you for your patience hearing. Thank you.
Thank you, Excellency. Excellencies, distinguished delegates, we come to the end of the roundtable, the two sessions of the roundtable. This, you would agree, was a very informative and interesting session in this roundtable. I think there are many things that we can remember, we can take and use, try to implement. Before we close, I would like to request Professor Anne, put you on the spot.
I'd be delighted to. Thank you.
Some quick messages,
Sure, absolutely, very brief. Don't worry.
We would lose this opportunity if you don't ask you to do that.
So I'll be really brief. So thank you for giving me this opportunity to hear the rich primary healthcare experiences of the region. It was really fascinating. So three very brief reflections. I was really pleased to hear of the emphasis on integration of services, because as my talk showed, lack of integration of primary healthcare is a big issue. It was also good to hear that countries are building on the traditional maternal and child health strengths of primary healthcare to add areas like NCDs, mental health, wellness services in order to adjust to changing disease burdens. And I was also pleased to hear that at least some good had come out of COVID, in the sense that you've tested innovations that are now being taken forward, like telemedicine, for example. And my final message is to encourage you, as you return to your countries, to examine the financing aspects of primary healthcare. Money is the fuel for primary healthcare. I'm sorry, I'm an economist. I have to say that. You need to make sure that your primary healthcare systems, that the financing of your primary healthcare system fully supports your ambitions for primary care. Thank you.
Thank you very much, Ms. Now, I have to invite our RD and then Poonam to give your reflection. Before I do that, I must say that many of the things that you heard here, the developments that we heard about in these countries, you have seen them, supported them, and been sitting at a vantage point to oversee all these things. And your role in this, I think, it should not go unsaid. And I feel that when you finish your term, you will be leaving an enviable legacy of health development in our region. And to say that we have come this far, although we have some distance to go, is telling part of your story. Please, Madam, your reflections.
Thank you very much, Dr. Palita, for these very generous words. And thank you, Excellencies, for sharing your experiences on PHC and also telling us what the system is today and how you intend to improve it. Now, I'd like to go back to what Anne said, since we are looking at PHC as a way to UHC. And she made a statement when she gave her presentation, which said that 75% of the projected gains from SDGs can be achieved through PHC. And that, I feel, is a very, very significant statement, and we need to give it some thought. We've heard from her how financing is important. She said it in her opening remarks. She again reiterated it. And it's like music to my ears, because you would recall that in every annual report, in my introduction, I have been pushing for more funding for the health sector. And we ourselves have seen in this region that where countries have allocated a sizable amount to the health sector from their total health expenditures, there is significant improvement in not only disease elimination, but also in building resilient health systems. And therefore, I think that is the crux of the message that she was giving us. And that is something that we need to take very seriously. COVID-19 couldn't have been a better example of that. In COVID-19, funding was available. There was huge political commitment for funding. There was no shortage at that time. So my plea really is that perhaps not at that level, but there should be more funding for the health sector if we want gains from the health sector. Many of you have heard of what happened in Alma-Ata in 78, or what happened in Astana in 2018, but perhaps very few know that PHC goes back in this region to 1920s. At that time, health units were set up in Sri Lanka and also in India. And we also have heard of the Bandung Conference in 1937, which was on rural hygiene, which was held by Indonesia. So we lay the ground there. This region goes back that far. There has been sizable progress after that. We've heard from the Honorable Minister of Bangladesh about community health clinics, and I have had personal experience of visiting the community health clinics. What struck me most really was that there was no shortage of medicines. And that is something which we emphasize when we talk of UHC. If we look at the two health indicators, 3.8.1, which covers essential health services, and 3.8.2, which looks at financial protection and protection from catastrophic expenditures. And where do these expenditures really occur? And this is what Anne referred to also. It really goes to medicines. And even where countries do provide free healthcare, medicines are still left for the patients to go and buy. And that is why medicines become extremely important. Out-of-pocket expenditures in our region are pretty high. We've seen that. And I think it's very, very important to address this. Community health clinics have addressed that in Bangladesh. I've seen myself how they are well stocked and how they are distributed to the patients when they come. And I was quite amazed. Of course, I visited this a number of years ago, maybe 5 years ago, but I was quite amazed to see that the community would get together and stock them. It was really not the government doing it. It was a community effort. Community was the one which was really stocking these medicines. Hence, the community knew what was the shortfall, and they could make up for it. India has also shared its example of comprehensive healthcare. That's what Anne referred to in a final note. And they have also tried to provide comprehensive and integrated healthcare in the wellness centers. And that's also, I've had the privilege of visiting, having the advantage of being based in India. So I've had numerous instances when I could go and see these health and wellness centers. And I was quite amazed at the provision of services there, including preventive services, which many of you have emphasized how important it is to provide preventive services. And the Honorable Minister also referred to the Community Health Workers Cadre, which they have started, which I feel is an extremely good addition. And her keynote, which she said, was that we have shifted from illness to wellness. And I think that is the way that we need to proceed. Maldives shared its PHC model in Fafu et al., which, as I mentioned in my opening address yesterday, I again had the privilege to visit and to inaugurate with him. And it really is it's a pilot, but a very fine example of how they can move on PHC, especially NCDs. And as mentioned by the Honorable Delegate from Bhutan, today, mortality is more from NCDs than from communicable disease. It varies from country to country, but we have seen that it's over 60% on an average in our region. So that is something that we need to address. NCDs have to be addressed at the primary care level. Very often we find that when we go to the tertiary care, they are overcrowded. And that's something that also came up by the Honorable Ministers. There's overcrowding there. Now, how do we really address that? PHC is the best approach, to encourage them to go to the PHC level. That would take care of the services that they need, and it would take care of those who really need tertiary care level to go to the tertiary care. Otherwise, overcrowding at the tertiary care really doesn't help, because people with common cold come there and people with very serious issues come there. And therefore, it leaves very little scope to attend to those who really need those kind of services. And there was an example shared of how PHC, you go to the PHC level, and yet when you need through telemedicine to be able to reach the tertiary care level, you can do that. And that, I think, is the way forward, which many of our countries are now adopting, using digitalization, using telemedicine to be able to reach people. COVID, when it came, and I truly do believe in it, that when there is a big disaster, it of course brings in a lot of despair, it brings in a lot of mortality. There is, people are upset at that time, but I've seen that it also provides an opportunity. So looking at the brighter side and the positive side, let's look at the opportunities that were provided. And lots of those have been shared by the Honorable Minister from Thailand, that how those opportunities then become a practice, because you see that these are opportunities which circumstances forced us to adopt. However, they are cost effective, and that is something easily done and the way to go. I have also had the opportunity to visit Timor-Leste, and I have seen how they provide services at the community level. Timor-Leste is really one of those, the latest country to join our region, because it got independent late. And yet I've seen how they geared up to the occasion and how they tried to get communities getting services at their doorstep. So they've organized that where they get all the services together, including advocacy, education, health education, and where the community can go, get services. And also there's a provision for advocacy there to tell mothers what to do, to tell, and mostly when I visited, I found mothers with their children there because they have perhaps more time and they're not working to be able to take their children to these clinics. Sri Lanka has been a shining example in our region of how PHC can be provided. Unfortunately, as the Minister of Health has mentioned to us, they've had an economic crisis, and yet she explained to us how they're coming out of it and how, and that was the example she gave, what I mentioned earlier, that how they're trying to combine telemedicine, tertiary level advice and guidance, for primary level services. And that is a cost-effective way in which to proceed. Indonesia has been doing a lot, and they shared with us what they have been doing at the PSC level, including standardized capacity building, which is extremely important. This is a region which has adopted a decade of strengthening human resources for health, and we have been looking at it very closely. And we have also seen gains from it. There have been gains from it. For example, there has been an increase in doctors. All countries of the region have been very carefully trying to augment the amount of professionals available per patient. That is a huge advantage. We have also seen the number of pharmacists going up, the amount of nurses going up. Unless we have human resources, it's very difficult to really be able to provide good health services. And by good, I mean quality health services, which is something many of you have emphasized, that it's not just enough to give health services. These should be quality health services. That's another way to avoid out-of-pocket expenditures. But when we provide health services and we say that health services are free, then we also have to see that they are quality health services that are free. Otherwise, patients rush to the private sector where it's available, and that is where out-of-pocket expenditures tend to rise. So thank you, Excellencies, for all the excellent comments and recommendations you've made. These will go a long way in charting the future course of our work in PHC in this region. Thanks once again.
Thank you very much, Madam Mardi, for your customarily brilliant wise comments. Shows all the experience and knowledge you have gained in this thing. Thank you very much once again. I will not try to summarize. I can't say anything more than what I heard from you. It's brilliant. Let me now thank our Excellencies and our distinguished delegates for this excellent participation in this roundtable and for your valuable contributions. The last word I'd like to say is when you go back home, please continue to think of PHC and UHC as you are doing now. With that, may I return to our MC, Dr. Sham, Dr. Amani.
Pleasure.
Please take over. The floor is yours.
Thank you, Dr. Palita. Thank you very much. It's a pleasure to hear all the distinguished guests and the delivery by RD, Madam. I share your point of view. It's very difficult to top up that kind of summary, very well-rounded. And I just also like to echo, I think, the sentiments felt by many in this room that the wealth of experience shared is definitely a big kind of offering of what I would call powerful messages about where to go next with PHC. With that being said, I would like to just emphasize that under the leadership of our host country, member states of the Southeast Asia region collectively developed and agreed on the Delhi Declaration on strengthening primary health care as a powerful pathway towards achieving universal health coverage. And it is now a moment for us to come together more and to champion PHC together. And that being said, I cordially invite you, dignitaries in alphabetical order by country, to demonstrate your commitment to strengthening PHC on the board, as you can see opposite to me. And with that, I would kindly invite the chief delegate from Bangladesh to take the first step forward, please. Thank you very much, Excellency. I next call on the kind delegate from Bhutan to take center stage, please. Thank you, Excellency. I next call on the distinguished delegate from the Democratic People's Republic of Korea to take center stage, please. Beautiful, thank you. I next call on the distinguished delegate from India to please take center stage. Many thanks, delegate. Many thanks, delegate and distinguished guest. Thank you. I next call on the chief delegate from Maldives to take center stage, please. Oh, sorry, I apologize, from Indonesia. I apologize. Thank you, Excellency. Thank you, Excellency. I next call on the chief delegate from the Maldives to take center stage, please. Thank you, Excellency. I then call on the chief delegate from Nepal, please, to take center stage. Many thanks, Excellency. I next call on the chief delegate from Sri Lanka to take center stage, please. Many thanks, Excellency. Many thanks. I next call on the Chief Delegate from Thailand to take center stage. Many thanks, Excellency. And I now kindly call on my chair, the Chief Delegate from Timor-Leste, to take center stage, please. Thank you, Excellency. Thank you very much. Last but not, of course, least and never least, I kindly call on our RD, Dr. Poonam Singh, to please take center stage on our behalf. Dr. Poonam has done it for on behalf of the Southeast Asia Regional Office, and she does it for the whole of WHO. Thank you very much, Dr. Poonam. Thank you very much. I therefore ask you to celebrate this time, this commitment. May I call all dignitaries to please come to the front of the LED screen, where you will kindly see at the foot of the floor a tag with the respective country names. I kindly ask you to take your steps forward. Madame RD, leading in the middle. It's very heavy, yeah. May I kindly request Madame RD to unfold the banner of commitment in championing primary health care together as one region and as one WHO. Please, a big round of applause and a big round of appreciation. We thank you all for your commitment. We thank you for the time and the effort. Thank you very much. Much appreciated. Thank you very much. Kindly return to your seats for us to be able to proceed to the last segment. Thank you very much, sir. I wish to we just give you a moment to take view of the declaration, the signatures. We thank you very much for the time and the effort you've given. We are at the end of the ministerial roundtable, and in this part of the session, I return to my esteemed chair to close the session on our behalf.
Excellencies, WHO Regional Director for Southeast Asia, Dr. Poonam Khetrapal Singh, distinguished representative, ladies and gentlemen. I would like to thank honorable ministers and heads of delegation for their active participation in this roundtable and on their leadership on these subjects. Your presence here and collective commitment speak to what we believe to be possible in our region, delivering on the promise of universal health coverage and health for all. Through focused attention to primary health care. I would also like to thank Dr. Poonam Khetrapal Singh, WHO RD, for her insights as well as her exemplary leadership in the region. We truly have come for over these last decades. I also thank to the WHO Secretary for making this ministerial roundtable session for really success. Last but not least, my special thank goes to Dr. Palita Abikun for spectrally moderating the session, to Professor Ann Mills to her keynote message, and to both for their contribution to the development of health system across our region. Finally, before moving from this agenda, I urge us to keep the spirits present in this room today, and together we strengthening primary health care across each of the country of the Southeast Asia region through implementation of the Delhi Declaration. I now declare the Minister Roundtable closed.
Excellencies, distinguished delegates, ladies and gentlemen, this is not part of the MRT, but very important part of MRT. As you all know, every year we celebrate achievements in the region, and we do it at the regional committee meeting. And you have heard yesterday, both from DG as well as RD, on the many achievements in this region. And today we even heard more, much more of success, achievements, and great work that the countries are doing. For the year 2021-22, we did not have such celebrations because you know why. The pandemic essentially put a hold on that. But as soon as the pandemic started to recede, our countries have accelerated effort. And today we are here to celebrate 6 achievements in 5 countries. So we prepared a citation and a plaque to commemorate that and to present it to you by the regional director. We do this not because we want to say that WHO did this. We do this to celebrate your leadership as ministers, as senior officers in the government, and to celebrate the hard work of our frontline workers who every day struggle with difficulties that we have heard, challenges that we have heard from the countries, yet they do great work to make these things possible. So without any further ado, what I would like to do is present to these countries the plaque, and we will keep the citation is rather large, but I would like to request your country delegates to please also take the citation. First, I would like to invite, where is Bangladesh plaque? My colleagues, where are you? Sorry. So for Bangladesh this year, we have two, which is the elimination of Kala-Azar and the elimination of leishmaniasis, both very important NTDs. All these eliminations were validated through careful evaluation of the data that we have by independent experts and following protocols that are established by WHO to do that. So we are quite confident that when we say that it has been achieved, it has been achieved. This one is Kazar. So this is first the plaque to Bangladesh, which Madam RD will present to His Excellency, the Minister from Bangladesh, on the achievement of Kala-Azar elimination. Yes. I also present the plaque for the achievement of elimination of leishmaniasis in Bangladesh. Yeah. Yeah. Thank you, Madam RD. I'm advised that perhaps if Madam RD could come here to present, they say camera angle is better. So, Madam, can you come here, please? So, for the next, we have three countries, Bhutan, DPRK, and Timor-Leste, to celebrate the achievement of the elimination of measles and rubella as endemic public health problems in their countries. As you know, our region is very important given the large population that we have. We have annually close to, if not more than 35 million birth cohort. So immunization is so important for this region. And I'm glad that all our countries do a tremendously great job in that. And this is to celebrate that achievement in three countries. So first, I would like to invite Dashupemba from Bhutan for RD to present the plaque for the achievement of elimination of measles and rubella as endemic public health problems. Yeah, okay. Next, I would like to invite His Excellency, the Ambassador from Democratic People's Republic of Korea, also to celebrate the elimination of measles and rubella as endemic public health problems. May I now invite Her Excellency, the Minister from Timor-Leste, also for celebrating the achievement of elimination of measles and rubella. And finally, I would like to invite His Excellency, the Minister from the Maldives. This is truly a first in the history of the world, I think, because nowhere till now have such a even been celebrated. That is the interruption of transmission of leprosy. Strangely, a disease that many people don't realize still is circulating and exists in many countries of the world. Maldives, after rigorous evaluation this year, have achieved that landmark in interrupting leprosy across the entire country. And to celebrate that, we would like to present this. Where are the books? Where's the book? You didn't put, I told you, distributed already. Finally, yes, Madam, please, you can go to that. Finally, to close all these things, I would like to request Excellencies for one small task. So every year, and yesterday, RD presented the report for last year, which was for a report for year 2021. Sorry, 2022. Every year, RD has been presenting a very detailed annual report on the work that is happening in the country and the achievement that countries have been making. We have pulled together last 10 years' work in the countries into one publication, which we are calling the Platinum Decade, the 10 years of achievement in health. And we would like to request Your Excellencies to, along with RD, if you would kindly release this. This will be followed by, bring the Lancet one. No, I don't need. Yeah. So may I, if you do not mind, Excellencies, if you would please kindly, did everybody get? Yeah. Yes. Yes. Yeah. If you would please kindly open it and then just hold it up for a minute. Oh, we go up there. Okay, okay, yeah. So sorry, if you don't mind, can you please come here so that we can all stand in a straight line, and then perhaps it would be easier to do that. Yeah. Yeah, 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 yeah. Yeah, you can open it. You can open it. Sorry. Can I help you? Can I help you open it? Yeah, it is. Yeah. 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 Sorry. He made such tight, he made such tight packing, you know?
Yeah, that's good.
Yeah.
Yeah. Yeah, it's all done. Yeah. Thank you.
Excuse me. Somebody, yeah. Yeah. Yeah, Excellencies, just 1 minute. So to celebrate the achievements by the flagships, the priority programs with Dr. Poonam started, the Lancet brought out a special issue this time to highlight the achievements of the 8 flagships that in the last 10 years, this region has been pursuing under the leadership of Dr. Poonam. So we would like also the distinguished delegates and Excellencies to kindly please release that as well. It's possible. Yeah, I think just now we can just correct it. We can. Yeah. Yeah, please.
Copy version of a journal.
Thank you very much, Excellencies. And this truly brings us to the end of this morning's function. Lunch is being served, and we will resume at 2 p.m. in the plenary hall again. For the drafting group, please, starting at 1 p.m., the drafting group will meet in the meeting room on the 20th floor. So please, 1 o'clock. Thank you very much. Yeah, hello. Yeah. Excellencies, sorry. The minister from Timor would like to request Excellencies for 1 second because she would like to make a present to our regional director, Dr. Poonam.
Hello, check, 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 check.
Hello, hello, hello.
Hello, 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 mic testing, check, 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 sound testing. Hello, 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 hello. Check, check, check. Hello, sound testing. Check, 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 check. 1, 2, 3. Hello, hello, hello. Audio testing. Hello, 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 hello. Hello, hello, mic testing. Hello, 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 sound testing. Check, 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 check. Hello, hello, hello. Hello, hello, is my testing. Check, sound testing. Hello, 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 hello.
ठीक है, ठीक है.
Hello, hello, hello. Hello, hello, hello. Sound test. 1, 2, 3. Check, 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 check. Hello, hello. Hello, mic test. Check, 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 check. Hello, hello, mic test. Check, 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 check. Hello, sound testing. Hello, hello, hello.
Excellencies, distinguished representative, welcome back. I thank you all for your active participation, insightful observation at the Ministerial Roundtable. I now call the meeting to order. Now onwards, for the intervention of the agenda items, I would appreciate maintenance a maximum time limit of 3 minutes. Accordingly, the traffic light will be green for 2 minutes and we turn amber for the last 1 minute. It will turn red once the allocated 3 minutes times is over. Let's now take up agenda 10. Governing body matters. As you may observe, this agenda items has 4 sub-items, so let us now take up sub-items 10.4, elective posts for governing body meetings. WHA, EB, and PBAC. Discussions on the remaining sub-items under this agenda will be taken up during the course of this meeting. Excellencies, the WHO Secretary's request that we consider and take a decision on the regional proposal for the elective post of office bearers for the 77th World Health Assembly on the 155th session of the WHO Executive Board, along with the membership of the WHO Executive Board, its Program Budget and Administration Committee, and also the Standing Committee on Pandemic and Emergency Preparedness and Response from our region. According to established practice, the proposal of elective posts of AB member and WHA office bearers from the region will now presented to facilitate decision by the regional committee. I request the secretaries to make the presentation.
Thank you, Madam Chair. Distinguished delegates, I have the pleasure to present the posts for the WHA, EB, and the PBAC from our region. As is customary practice at these governing body meetings, member states are nominated in rotation, and at every one of these sessions every year, we have to nominate. So, next slide. We are required to nominate to the 77th World Health Assembly in May next year, the Vice President for the World Health Assembly, the Chairperson for Committee A, and then member for Committee on Credentials. Also, we are required to nominate for the 155th session of the WHO Executive Board to be held again in May next year, 2024, nomination of 1 EB member to replace Timor-Leste, whose term expires then, and then nominate Vice Chairperson. For the PBAC, which is the Program Budget and Administration Committee, we have to nominate 1 member from among the EB members from the Southeast Asia to replace Maldives, whose term also expires. Then there is the Standing Committee on Health Emergency Prevention, Preparedness and Response, for which we are required to nominate 1 member from amongst EB members from our region to replace Timor-Leste. Next. Therefore, the regional suggestion for the elective posts from Southeast Asia region for 77th World Health Assembly is proposed as follows. For the post of Vice President, it is proposed Sri Lanka. For the Chair of Committee A, India is proposed. And for member of Committee on Credentials, Bhutan. Next slide. For the elective posts from Southeast Asia region for the 155th session of the WHO Executive Board, current board members are DPR Korea, Maldives, and Timor-Leste. And Timor-Leste term expires May next year, 2024. And in replacement, the member state from Southeast Asia region proposed
is Thailand, that who will replace Timor. And then as vice chair for the executive board, Maldives is proposed. Next, please. Yeah. The current PBAC members from the Southeast Asia region are DPR Korea and Maldives. It is proposed as Maldives' term expires, to be replaced by Thailand. Next, please. The current membership on the Standing Committee from Southeast Asia region for the Health Emergency Prevention Preparedness Response are Maldives and Timor-Leste, and the member state from the region proposed to replace Timor-Leste, whose term expires in May 2024, is DPR Korea. Next, please. So these are the posts that have to be filled, and these are the suggestions which were presented to the HLP, and then now it is being presented to you at the RC meeting. Thank you.
Thank you. Now I open the floor for comments or observation on the proposal. In absence of any observation, we approve the proposal as presented by WHO Secretary. The regional director may inform WHO headquarters accordingly. Thank you. Excellencies, distinguished representative, let us now take up agenda item 7, number 7, programs, budget matters. I wish to reiterate that this agenda item has been extensively deliberated upon by our representative at 16 meeting on the Subcommittee on Policy and Program Development and Management, held on 6 September 2023. They made recommendation for consideration by this 76th session of the Regional Committee. The working papers available online provide full background on each item. We may, therefore, like to focus our deliberation on the key points which have been placed in the text box on the cover page of each working paper. As you will observe, agenda item 7 has 4 sub-items. Let us first take up sub-item 7.1, Program Budget 2022 until 2023, Implementation and Midterm Review. I draw your attention to documents CAA/RC76/4 Ref.1. Consistent with WHO accountability framework, this working paper provides an update on the implementation on the program budget 2022-2023 in the WHO Southeast Asia region for the first 19 months, January 2022 on July 2023, and midterm review of the first 12 months of the biennium, January till December 2022, as presented to member states during the SPPDM meeting. The further provide an update status to member states. The implementation that up to 30 September 2023 is provided as Annexure 8, 5 tables given as Annexure 8A, 8B, 8C, 8D, and 8E. I'm pleased to note that as 30 September 2023, the revised approved regional program budget of USD 530.2 million is full funded. The utilization rate is 87% against both the approved program budget as well as distributed resources. The CE Asian region is leading all Mayor office in terms of utilization against distributed resources. I'm sure that the region will continue to engage with the member state, take steps to strengthening the support extending the country in recovering from the impact of COVID-19 pandemic and accelerated progress towards the achievement of the Sustainable Development Goals with a force to fully implement Program Budget 2022 until 2023. The working paper, along with SPPDM recommendation, is presented to the 76th session of the WHO Regional Committee for Southeast Asia for its consideration. I now give the floor to the honorable delegates to make their comments and observation on the subject. Now I give to Indonesian, please. Indonesian for intervention, please.
Yeah, thank you, Chair. We would like to thank the Secretariat for preparing the working paper on this agenda item. Indonesia welcomes the Secretariat's endeavor to provide the Member States with a better quality presentation of the Program Budget 2020 and 2023 implementation reports. It is a comprehensive presentation on the progress of financial implementation. The 13th General Program of Work Result Framework and the ongoing review of the Program Budget 2022-2023. As of July 31, 2023, the revised approved program budget for the Southeast Asian region stands at 90% funded, which indicates strong support and commitment from member states. Implementation has reached 68% against the revised approved budget and 69% against total distributed resources, reflecting a noteworthy effort to allocate resources effectively. Utilization, comprising expenditures and encumbrance, stands at 81%, which showcases the region's dedication to delivering on its commitments. A comparative presentation on flexible funds based on geographical and technical outcomes is useful to understand and how effective and impactful the Program Budget 2022-2023 is. Nevertheless, we expect that it could be linked with WHO's cost saving and efficiency gains that have been depicted in the working paper for a better understanding on the budget implementation. Indonesia again appreciates the Secretariat's effort to retain efficiency in the current budget the Program Budget 2022-2023 implementation to the end of the biennium. Therefore, it would promote the value of money in the program budget. We also advise the total frequency and scope of reporting are adjusted by the needs fulfilling the accountability and transparency expect, but at the same time depicting the efforts to achieve the cost effectiveness of the program budget implementation. However, Indonesia has faced challenges in optimizing the use of WHO's financial resources, primarily due to issues with the Agreement for Performance of Work, APW mechanism. This matter has been focal point of concern as it impacts the country's ability to fully harness and available resources for public health initiatives. Indonesia remains committed to working collaboratively with the WHO to address these challenges and streamline the utilization of resources effectively, ensuring that the collective goals of the program budget are achieved to benefit the country and its people. I thank you.
Thank you, Indonesian. For the second one is intervention from India.
Thank you, Chair. India would appreciate the efforts made by WHO Zero in developing detailed working paper encapsulating the tireless efforts and significant progress achieved during midterm review of program budget 22 and 23. This review, encompassing the time frame up to the culmination of December 2022, provides a comprehensive overview of the strides taken by WHO Zero in fulfilling its commitments. As outlined in the report, it is indicated that approved program budget for the region, which has undergone revision, has received funding to the extent of 99%, amounting to US dollars 525.3 million, out of the allocated USD 530.2 million. Concurrently, the implementation phase represented by expenditure has reached 68%, while combined with utilization encompassing both expenditure and encumbrances has attained a level of 81%. It is suggested that report should support approaches to address and bridge the identified gaps between the utilization versus the approved program budget. The achievements highlighted in the report including decline in malaria cases, establishment of WHO Global Center for Traditional Medicine in Jamnagar, Gujarat, the Quit Tobacco app, the implementation of regional civil registration and vital statistics is praiseworthy. Chair, India wishes to highlight that the report should encompass detailed directives from the WHO Secretariat outlining the actions to expedite advancements toward realizing GPW 13 triple billion targets and the Sustainable Development Goals. Furthermore, the report should elucidate the measures the WHO Secretariat can adopt to guarantee the complete execution of the allocated resources from the flexible fund for the program budget 22 and 23. We suggest that results measurement framework of GPW 13 should be incorporate changing needs and challenges in the global health to enhance the impact of WHO strategic priorities. We also look forward to enhanced engagements of member states with country offices for better coordination in program implementation, regular reporting, monitoring, as well as performance assessment. Thank you.
Thank you. Now give the floor to Maldives, please.
Thank you, Chair. Maldives appreciates the report by Secretariat on this agenda item. Maldives acknowledges the extension of the 13th General Program of Work to 2025 to intensify and strengthen the support to countries in recovering the impact of COVID-19 pandemic. It is a vital element in ensuring the implementation of the triple billion strategy and achieving the sustainable development goals. Maldives notes the progress made on midterm review of the program budget 22-23 and the financing and implementation of the program budget for the period and of the first 9 months of the biennium. We appreciate the progress report that was presented, in which included the key performance indicators, and we note the increase in the revised program budget in the base budget segment up to 16%, in the CRO region being the lead in utilization among all the regions. Honorable Chair, Maldives applauds the achievements and progress maintained by member states and WHO in the effective implementation of the programmatic activities battling the COVID-19 pandemic. Further, we highlight the progress made in strengthening country capacity in data and innovation. We thank WHO for the effective and efficient support provided to the member states based on our needs. Maldives requests WHO to continue support to countries in recovering from the impact of COVID-19 pandemic to attain better health systems and to ensure full implementation of the flexible fund allocations. We further request to continue with the bottom-up planning processes, including the joint planning process to ensure close and regular reporting, monitoring, and performance assessment of for approved revised program budget for analysis on efficiency gains. Maldives is committed in the implementation of the program budget and report to member states the achievements based on results measurement framework of the 13 GPW, as well work towards better health outcomes and progress towards regional and global public health goals and targets. Thank you.
Thank you, Maldives. Now I give the floor to Thailand, please.
Thank you, Chair. Thailand thanks the Secretariat for the comprehensive report, including midterm review, which summarizing the achievements of the implementation across triple billion targets in 2022. These achievements contribute by collective efforts between member states, WHO, and relevant partners. The better outcomes across three strategic priorities are well noted. This is not only the financial resources from the WHO, but also across the collaboration between the WHO and member states through technical support. Thailand appreciates the continuous effort of the regional director to drive impact of the WHO work at the country level by prioritizing budget allocation to the WHO country office, with supporting national program through Country Cooperation Strategy or CCS. This uniqueness of our CCS programs is that we use financial support from the WHO as the lubricant at 30% maximum, while the major resources are from domestic contributors. This will lead to more sustainable of our work at country level. Thank you, Chair.
Thank you. Now give the floor to Bangladesh, please.
Thank you, sir. We appreciate the WHO Secretariat for this report on the implementation and midterm review of Program Budget 2022-2023. Whose support the Bangladesh in this biennium has contributed significantly to tackling a variety of health issues, including ensuring primary health care, communicable and non-communicable diseases. With strong coordination and collaboration between us, funding and technical support from WHO has been critical. With the extended WHO Bangladesh Country Coordination Strategy 2022 to 2025, the Ministry of Health and Family Welfare and WHO has been working together toward achieving SDG and UHC. We acknowledge and agree with the report that significant progress has been made in the region and in the Bangladesh. Ministry of Health and Family Welfare and WHO are regularly monitoring the progress by monthly monitoring meeting and via biennial GWCC or Government WHO Coordination Committee meeting. We also had a dialogue with a representative from CRO WCO Bangladesh Review Mission on the progress made. Bangladesh is fully committed to work with WHO and member states towards achieving a triple billion targets as well as strategic priorities of Southeast Asia region. Thank you.
Thank you, delegates. Now I give the floor to Timor-Leste, please.
Thank you, Madam Chair. Timor-Leste express its gratitude to WHO, especially to Madam RD, for your most generous support and making sure more than 80% funds are available at this country level. Timor-Leste recognizes that the COVID-19 pandemic has deprived the world from achieving most of the triple billion target and the health-related sustainable development goals and call for urgent action to accelerate the progress. Timor-Leste, with the assistance of WHO country office, is implementing all the possible intervention to restore the health system to the pre-COVID state and ensure health services accessible to all the people in the country. During the country biennium 2022-2023, WHO Country Office has been able to mobilize resources worth 18 million in the base segment and nearly 12 million under outbreak crisis and response plan. This resource mobilization and its implementation under different GPW strategy priority has greatly helped Timor-Leste health system to recovery and build a resilient health system. The utilization of the available resource stand at the 60% for the base segment and 99% for the outbreak crisis and response plan. Timor-Leste is confident to fully utilize the approved program budget for 2022 and 2023. Timor-Leste also wants to acknowledge and thank the donor for their support in strengthening the Timor-Leste health system. Midterm review, Timor-Leste expressed appreciation to WHO for the support of the midterm review in 2022. This significant task will carry out in order to access the accomplishment of the anticipated deliverable and pinpoint any deficiency for 2023. Out of the 43 key performance indicator KPIs, Timor-Leste had achieved exceptionally well by obtaining 90% for green quality and 56% green and 26% for yellow, and not single KPI received a red rating. With continued technical support from WHO, Timor-Leste strongly believes to enhance its KPI indicator by half of each indicator by 2023, from yellow to green and from the green to the green quality. I thank you, Madam Chair.
Thank you, delegates from Timor-Leste. Now give the floor to delegates from Bangladesh, please. Is a mistake here from Sri Lanka, please.
Thank you, Chair. Sri Lanka appreciately note this working paper which provides an update on the implementation of program budget 2022-2023 and the 13% of increase of the base segment for the Southeast Asian region. As Southeast East Asian region is leading out of all major offices in terms of utilization against distributed resources, hope as a region also to utilize maximally the distributed funds. Sri Lanka has been able to perform high in the following output areas 1.1.1. Countries enabled to provide high quality people-centered health services based on primary healthcare services, based on primary healthcare strategies and comprehensive essential service packages. Appreciate the renewed drive for health equity, the results framework to measure country progress and identify the contribution of the secretariat and reported annually using the framework. Sri Lanka noted that effort need to be focused on National Action Plan for Hepatitis developed in line with WHO guideline, costed and in implementation. We appreciate the facilitation received from the regional office as well as the country office, and Sri Lanka will strive to continue engaging and facilitating collaborative approaches for successful implementation of the programs at the country level. Thank you.
Thank you, honorable delegates from Sri Lanka. Now give the floor to delegates from Bhutan, please.
Thank you, Chair. Bhutan notes with appreciation the Secretariat report on the program budget 2022-2023 implementation and midterm review. We would like to acknowledge the organization for coordinating and arranging a series of consultations and exercises to finalize and successfully operationalizing the work plan for the program budget 2022-2023. The lessons learned from the COVID-19 pandemic response have been the basis for driving our planning exercise. During this process, our discussions were centered on how best we can achieve the 4 key strategic focus areas that shape the program budget 2022-2023. We are particularly pleased to note that there is a significant overall utilization of program budget, 93% against the approved program budget. We note that the program budget 2022-2023 has made important contributions to the member states during the times of COVID-19 response. There is also increased allocation as so relevant to strengthen the WHO's support to member countries in recovering from the impact of COVID-19 pandemic and accelerate progress towards the achievement of the GPW General Program 1.3 triple billion targets and sustainable development goals. We would like to thank the WHO CRO for ensuring adequate resource allocation to the member states and for their leadership. Thank you.
Thank you, honorable delegates from Bhutan. Now, give the floor to DPR Korea, please.
Thank you, Chair. The DPRK delegation would like to express thanks to WHO CRO and WHO country offices for their efforts to implement successfully the cooperative work plan of the member states amidst many challenges caused by the global COVID-19 pandemic. As in the previous biennium, we had to overcome major obstacles and difficulties in the implementation of the current biennium 2022-2023. Our delegation appreciates the regional office and our country office for their active support to medical supplies, including emergency health kits and essential medicines, which contributed to the promotion of health of our people. Our country, as a WHO member state, achieved many successes in implementing faithfully the work plans and was at the top in the regional implementation rate in the past. However, its implementation rate of the current biennial work plan is low due to many difficulties in recent years caused by the global pandemic. The planned budget of the current biennium was about 11,110,000 US dollars, but only 5,600,000 US dollars were allocated. Still worse, the implementation rate versus planned budget is 35.8%, and the implementation rate versus budgeted fund is 70%. In particular, the DFC activity, one of the WHO main support areas, has not been conducted as planned with AC fund in the current biennium. In the work plan, about 30 DFC activities were planned, but none of them has been implemented for various reasons. Among the activities planned in the current work plan, no activity has been carried out with the AC fund except the procurement of AIDS testing kits with an amount of 42,000 US dollars and blood bags totaling 210,000 US dollars. For the present, we must try to utilize all the budgeted fund during the remaining period while carrying over the Gavi fund with an amount of 1.19 million US dollars to the next biennium. Next biennium, 2024-2025 work plan should be implemented successfully, making good use of the past experiences while thoroughly overcoming the shortcomings and weaknesses. The DPRK government will fulfill its responsibility and role as a member state of the WHO by fully carrying out all activities reflected in the next work plan in active cooperation with CRO and country office. Thank you.
Thank you. Thank you, honorable delegates, for all your comments and observation. Now I invited WHO Secretary to respond to their observation and comments made by distinguished delegates.
Thank you, Madam Chair. First of all, I would like to thank all the distinguished delegates for your valuable inputs on that, on the agenda item. I also want to thank all of you for your very supportive statements for the work of WHO in your countries. We also appreciate the great appreciation that you express of WHO support, both technical as well as financial. I think there were no major questions raised from the distinguished speakers, except for the mention about APW mechanism with countries, I would like to clarify that the current procedure by which, or the mechanism by which we provide cash to the government is through the DFC mechanisms. And that APW is more for very specific work given either to institutions or organizations or experts on a limited basis. So APW generally is not the mechanism that go with, but DFC is. So I just want to clarify that. I also wanted to highlight, and it has been said many times, this region is unique, has been unique in many ways. But one of the most important thing has been our regional directors focus on making sure that 80% of resources went to the countries. And even the 20% that is operated from the regional office, which is distributed among the technical departments, again, that part also goes to support the activities in the countries only. So in effect, actually, close to 90% or more of the resources are focused on work in the countries, and I think it is the result of that you have seen over the years, the many achievements that you made. The reality is that for the last several biennia, our planning envelope has been more or less the same. So we have been operating essentially with a zero growth planning envelope. And for the next biennium also, we will be doing that. But the organization, WHO, at all levels, make all effort to raise the resources needed. And I think we have been fairly successful in raising the resources that we plan to implement. And we hope that for the next biennium also, we will be able to succeed in that. I think the most important thing in implementing, although in the governing bodies where member states participate in EB or in World Assembly, every now and then we hear that WHO is not a funding organization. WHO is a technical organization, and therefore the money that is available is to support WHO's technical support to you. But in our region, and also in many regions, except maybe one or two regions where the money does not necessarily flow to the countries as such. But in our region, our focus is to ensure that you get as much support that we can mobilize, because that is where it makes a greatest impact. And we in WHO are committed to continue to do that, and we will do so. So with that, if Madam RD, you would like to make any comment.
Thank you very much. Just to add to what the DPM has already said, there was some concern raised about the implementation, and it was raised by a couple of member states here. Let me mention in that regard that our program budget, which was approved, the original program budget for 22-23 was 476.2 million. That went up in the revised budget by 54 million in the base segment. So our final budget was then 480.3 million. That itself posed a challenge. So therefore, we need to keep in mind that additional amount that we got. Secondly, it is important for us to note what was already said by the DPM, that a large segment of what we get goes to our country offices. 80% of our budget is at the country level. And we work hard with our countries, our country offices, and the national country focal points work together to see that implementation is done. I would also like to put on record that the midterm results program budget report was presented, and this looks at the implementation of the first year of the program budget, implementation against the 3 billion targets. And when we look at that, we find that there were 6 country impact stories that were developed from the Southeast Asia region. What you see before you, Excellencies, is the implementation when we had the SPPDM. And there is a gap between that and today. So if we look at the figures of implementation today, we find an increase in the implementation. And we still have 2 months to go before the biennium closes. And therefore, we are working hard to see that, yes, we are able to implement whatever was planned. And there is, less of a surrender from our region. We do find that if we look at the figures, that the implementation was 28% for staff costs and 72% for activities. And we are the only region which spends so little on staff costs. If we spend more on staff costs, our implementation would be much higher. It's so easy to implement where you put towards staff. It's much more difficult to implement when you take a major part of your budget to activities. And therefore, that's something that we need to keep in mind. If we look at what we did in the COVID response, we find that our implementation there is much better. Not only is it 80% went to the countries as in the regular program budget, but 90% of the resources that were mobilized for COVID response went at country level. And there we find the implementation rates much higher. I therefore would like to assure you that we leave no stone unturned to see that implementation is done. The DPM regularly monitors this with the directors and the WHO country offices. All of us work hard to ensure that we are able to implement what we have planned. And that takes us to the planning. And you would find that in the next biennium, we are looking very closely at our work plans. We are looking very closely at our human resource plans so that we are better prepared as far as implementation is concerned. Thank you.
Thank you, RD, Dr. Singh. Excellencies, distinguished representative, let us take up the next sub-item under agenda item 7, that is 7.2, Program Budget 2024-2025. I draw your attention to documents CEA/RC 76/5 and CEA/RC 76/5 info.1 and CAA/RC 76/5 info.2. The program budget 2024-2025 was approved by the 76th World Health Assembly in Geneva in May 2023 via resolution WHA 76.1. The program budget 2024-2025 is unique in reflecting a new approach to the pandemic response, together with a greater country focus than ever before, and has more efficient feature and new presentation formats. The working paper presents an overview of the approved program budget 2024-2025 with details of the region program budget, update on the regional operational planning process, and the way forward is implementation. The full approved program budget for 2024-2025 is provided as information document CA/RC 76/5 inf.1. The resolution WHA 76.1 approving the program budget 2024-2025 is also provided as information document CEA/RC 76/5 inf.documents.2. The working paper and recommendation of the SPPDM meeting along with the two information documents are presented to the 76th session of the WHO Regional Committee for Southeast Asia for its consideration and decision. I now open the floor for honorable delegates to make their comments and observation on this subject. Now I give the floor to delegates from Bangladesh, please.
Thank you, Chair. We express our gratitude to the WHO Secretariat for approving the program budget for 2024-2025. We highly value WHO's support to Bangladesh during this biennium, which has been instrumental in addressing a diverse range of health challenges, including primary health care, health system strengthening, increasing health workforce capacity, emergency pandemic preparedness, etc. The financial assistance and technical support provided by WHO have played a pivotal role, emphasizing the significance of our coordinated efforts and collaboration. We acknowledge that 2024-2025 is the final biennium of the current General Program Work 13. The proposed budget incorporated lessons learned from the COVID-19 pandemic. We welcome WHO's continuing effort to strengthen transparency, accountability, and compliance, and recognizing the importance of allocating sustainable and adequate funding across all the WHO offices. We agree that suggested recommendation for member states regarding the implementation of program budget for 2024-2025. Our active collaboration with the WHO country office has been ongoing, aligning with the results framework of GPW 13 and emphasizing a bottom-up planning approach focused on results. Additionally, the Government of Bangladesh and the WHO country office are deeply engaged in joint efforts to formulate operational plans for the program budget 2024-2025. This collaborative process involves a series of formal and informal discussions as well as workshops conducted at the national level. Bangladesh is fully committed to work with WHO and member states towards achieving the triple billion targets as well as strategic priorities of Southeast Asia region. Thank you, Chair.
Thank you. Now I give the floor for honorable delegates from Bhutan, please.
Thank you, Chair. Bhutan welcomes the proposed program budget 2024-2025 as presented. It is heartening to note the preparation of program budget 2024-2025 comes at a very critical time when the pandemic has worsened the health developmental gains. Bhutan also notes that GPW 13 extension till 2025 to meet the triple billion targets and health-related sustainable development goals. Under the technical leadership of the WHO country office, Bhutan has developed draft program PB 2024-2025. We look forward to the further consultation and guidance of WHO in the finalization and operationalizing of PB 2024-2025. We recognize the efforts of the organization to promote results-oriented planning and budgeting and country prioritization priorities. Thank you.
Thank you. Now I give the floor to honorable delegates from Timor-Leste, please.
Thank you, Madam Chair. Timor-Leste appreciate the work of WHO Secretariat in addressing the member state demand for more transparency and more participatory approach in the development of the program budget in general, and more specifically in the prioritization process. Timor-Leste, with the assistance from WHO country office, has formulated the program budget for 2024-2025 through a consultation process, which has been a practice in the country. The proposed output prioritization for 2024-2025 is in harmony with the country cooperation strategy and UN Sustainable Development Cooperation Strategy and the National Health Strategic Plan. The prioritization will enable us to allocate limited capacity and resources in the areas where it will optimize its impact and help us to achieve the results set out under GPW 13. Timor-Leste has prioritized 21 outputs, 6 each in the high, the medium priority, and 9 in the low priority category, spread across all 4 GPW strategy priorities. The approved program budget for 2024-2025 for Timor-Leste is 13.8 million USD. Timor-Leste is confident that together with WHO Country Office, we will be able to build on the progress made during the current program budget to achieve desired result, ensuring the healthy life for all Timorese people. We once again thank you, Madam Ardi, for institutionalization, transparent and consultation process for the development of the program budget in the region. I thank you, Madam Chair.
Thank you. Now I give the floor to honorable delegates from Sri Lanka, please.
Thank you, Chair. Sri Lanka appreciate the extension of GPW 13 up to 2025, enabling to intensify and progress towards the triple billion targets and enabling countries to act on lessons learned from the pandemic and strategically investments in regional and country priorities. This extension provides continuity and stability and maintains the existing results framework for reporting during the extension period. Sri Lanka has engaged increasingly with WHO Country Office, especially during the bottom-up prioritization process, and have developed draft WHO collaborated MOH Biennium Activity Plan 2024-2025. During this process, engaged in exercise on output identification and strategic deliverables, NPO's discussion on strategic deliverables with national counterparts and high-level MOH officials, meeting on the tool and exercise, meeting to score output with all technical DDGs and additional secretaries, scored output based on criteria, a meeting on monitoring of implementation of Ministry of Health, WHO joint activities. We appreciate WHO efforts to involve other partners and stakeholders to identify country priorities and needs. Appreciate WHO assistance in collaborating with other non-governmental organizations to ensure novel financing mechanisms, implementation mechanisms such as relating to health promotion and social mobilization, as well as on strengthening data and innovation. Note the core predictability country presence CPCP model designated to ensure the secretariat deliverables on its commitments while strengthening technical capacity at the country level. Priority outcomes by WHO Country Office include high priorities in 1.1 and essential services in 2.1, emergency preparedness, and 3.2, risk factor reduce, while medium priorities were in 1.1 and financial hardships in 1.2, medicines were in 2.3, emergency detection and response, and data in 4.1 outputs. These coincide well with the three main overarching objectives of approval program budget 2024-25 to strengthen country capacity to accelerate progress toward the triple billion targets, to continue the work the previous budget 2022-23 to further strengthening accountability and transparency. Sri Lanka aims for 5 impact results with WHO support on sustainable health financing strategy available and implemented, NCD-related premature deaths reduced, prevalence of mental health and neurological disorders is known in the country, and the DHS survey 2023-24 finalized, and the patient safety ensured in all health facilities. We appreciate all the assistance received from the regional office and the regional director and the country office and the country representative during the preparation of the 2024-25 program budget, as well as the WHO headquarters to address the support need requested to operationalize the program budget 2024-25. Thank you.
Thank you. Now give the floor to honorable delegates Nepal, please.
Thank you, Madam Chair. The approval of the program budget 2024-25 by the 76th World Health Assembly in Geneva in May 2023 is shaped at a time when the world is recovering from the coronavirus COVID-19 pandemic. As the program budget 2024-25 is unique in reflecting a new approach to the pandemic response and has more efficient features and a new presentation format and benefits from a 20% increment in assessed contributions. It recognizes the urgent need for the country to speed up their pandemic recovery processes and build resilient health systems that protect against future health challenges. The program budget 2024-25 focuses on strengthening country capacity, continuing the work defined by the last program budget, and strengthening accountability and transparency in financing governance. We are aware that the program budget 2024-25 is the last budget to be prepared in line with the 13th General Program of Work, and successful implementation of it is mandatory. Therefore, Nepal appreciates and expresses gratitude to the WHO Country Office as well as CRO for the continued support for the successful implementation of the 2024-25 budget. I thank you, Madam Chair.
Thank you. Now I give the floor to honorable delegates from India, please.
Thank you, Chair. India acknowledges the significance of endorsing the program budget 24 and 25 with a 20% increase in the assessed contribution, which paves the way towards a more sustainably financed organization. It also stands out in its distinctiveness in portraying a novel strategy for addressing the pandemic. This budget embodies a heightened emphasis on individual countries incorporating enhanced efficiency and adopting a fresh presentation style. India firmly believes that the program budget 24 and 25 comes at a pivotal moment. Actions are already being implemented to help the region to recover from the recent challenges. The 2024 biennium will be critical for region's efforts to continue the recovery, accelerate the actions, and undertake innovations to advance health agenda and reduce inequities in the region within the countries. India appreciates the hard work put by WHO in developing program budget portal, which embeds graphical charts for easy understanding and statistics and comparison aspects. However, the mechanism of strategies priorities adopted by WHO needs further revision to reduce the complexity involved. We would also request WHO to provide information on the portal with as much details as possible, with microscopic expenditure involved even at the sub-priority levels. India also appreciates and through consultative process for the finalization of program budget 24 and 25, which provides for heightened focus on special programs with specific concern in R&D and training in human reproduction, tropical diseases, and infectious diseases of poverty. Digital health is a proven accelerator to advance health outcomes, achieve universal health coverage, and health-related sustainable development goals. India proposes to integrate the Global Initiative on Digital Health, a WHO-managed network launched during India's G20 presidency, to monitor progress on the 12 outcomes and 42 outputs evaluated in alignment with the 500,000 targets. Output scorecard and qualitative country case studies also are requested. In formulating the operational plan for the upcoming period of 24 and 25, India places significant emphasis on augmenting financial allocation towards enhancing the capabilities within the health sector. The emphasis should be particularly pronounced in domains such as advancement of healthcare personnel, fostering health research, and innovation. Additionally, India underscores the pivotal nature of prioritizing investments in digital health infrastructure and cutting-edge technologies, recognizing the potential to bolster the foundations of health systems. India would like to acknowledge the efforts of WHO in formulating the program budget 24-25 and believes that enhancing digital enhancement can ensure accountability, transparency, and measure progress towards desired outcomes. Thank you.
Thank you. Now I give the floor to honorable delegates from Indonesia.
Thank you, Chair. Indonesia expresses its appreciation for WHO Secretariat's efforts to enhance the presentation of the proposed program budget 2024-2025 through the program budget digital platform, providing member states with improved access to information. Indonesia commends the transparency and best practices demonstrated by WHO's Digital Budget Platform Program, which provides member states with vital information on outcome, output, priorities, and budget allocations. We encourage the Secretariat to continue implementing such transparent measures. The program budget 2024-2025 is the product of meticulous approach that blends data-driven insight with a more robust and inclusive consultative process, commencing with the prioritizations at the country level. This approach has yielded significant improvements in both priority determination and country-specific initiatives, while simultaneously advancing the goals of transparency, accountability, and efficiency. Furthermore, it has fostered a more seamless connection between the prioritization process and the budget allocation. Furthermore, Indonesia hopes that the positive practices established in the development of the budget program will be sustained through ongoing collaboration, communication, and coordination between member states and WHO country office. I thank you.
Thank you. Now I give the floor to the honorable delegates from Maldives, please.
Thank you, Chair. Maldives would like to comment the reports by Secretariat on progress made on the revision of Program Budget 2022 to 2023 and to approve the extension of the period of the 13th General Program of Work from 2023 to 2025 through the resolution WHA 75.6 in 2022. Maldives recognizes the proposed program budget 2024 to 2025 is built on country priorities, emphasizing on three overarching objectives and continuing the investment in the normative function of the organization and country capacity building to accelerate progress towards achieving the triple millennium target. Maldives welcomes the holistic approach adopted and substantial efforts by the Secretariat in seeking efficient way to deliver its work, including strengthening of the transparency, accountability, and compliances, as well as measure taken the allocating adequate and sustainable funds equitable incorporating guidance from the IGAL member states task groups. On this note, Maldives believes that allocation of the financial resources must be accompanied by progress monitoring and expectation of measurable results. Honorable Chair, Maldives acknowledges the authorization of budget transfer among the 4 strategic priorities and authorizing additional expenditures in the emergency operations and special program as a result of additional governance and resource mobilization mechanism. Honorable Chair, on the final note, Maldives looks forward for the continued engagement in the implementation of 13th General Program work result framework with more focus on result-based bottom-up planning, develop operational plan for program budget 2024 to 2025 with a focus on achieving impact at the country level through more focused country support plan. Thank you.
Thank you. Now I give the floor to delegates from DPR Korea,
please.
Thank you, Chair. First of all, the DPRK delegation would like to appreciate and welcome the program budget to 2024-2025 prepared to ensure greater share for member countries compared with previous biennium so that they can speed up their pandemic recovery process. Ministry of Public Health and WHO country office in the DPR Korea are now actively working on specific and practical plan of activities under 2024-2025 work plan. The country budget ceiling for the next biennium is around 19 million USD, that is 8 million USD more than the current biennium, which shows that WHO attaches great significance to the country offices where the most cooperation activities are practically conducted. But all efforts should be made for this budget ceiling to be allocated, lest it remains only as a planned figure on paper. As I mentioned on the discussion of the previous agenda, the planned budget was 13 million USD for the current biennium when the work plan was approved, but it has been reduced to 11 million USD after 1 year and only 5.6 million USD, which accounts for 50% of the planned budget was allocated. Ministry of Public Health will try its best to make maximum use of the allocated fund in time in close cooperation with the country office in the next biennium. Main cooperation should be directed to technical support such as DFC activities as well as the provision of medical equipment and supplies. With regard to the next biennium work plan, we would hope that the WHO can mobilize more VC funds, including OCR and CERF, thus contributing actively to the global priority programs such as TB and NCD programs. As the TB and NCD accounts for majority of the global mortality and morbidity, they are deliberated as the main agenda item of the high-level meetings of the UN General Assembly, resulting in the adoption of declarations. In this regard, we would like the WHO to allocate additional VC funds to the country offices for accelerating implementation of the program activities to prevent and control the TB and NCDs. The DPRK government will in the future to discharge its role as a member state of the WHO by fully implementing all the activities reflected in the work plan in active cooperation of CRO and country office. Thank you.
Thank you. Now I give the floor to honorable delegates from Thailand, please.
Thank you, Chair. Thailand notes with appreciation the improvement in the process of developing program budget 2024-25 and the proposed expect concrete outcome. We see the key roles of the WHO in improving access to quality essential health services, preparing for health emergencies at country level, and empowering society through addressing health risk factors, which are social and commercial determinants of health. Through this law are obviously beyond strengthening health system. We fully concur and call for closer collaboration with other sectors through effective multi-sectoral action for health. For Sierra region, the base program for 2024-25 will increase by 14%. This will allow us to have more resources to support implementation across key areas. Thailand commended the leadership by RD Dr. Bunam in continue supporting the work at country level. This is reflected by country allocation in Sierra is nearly 75% of the total regional budget. This is the second largest proportion among all the major offices. Chair, one challenge is how to manage the program budget during the transition between General Program of Works 13 in 2024 and GPW 14 in 2025. Thailand requests the Secretariat to clarify this challenge. Finally, despite the available resources to support country, efficient use of final resources for prioritized programs, synergizing with regional work or group practice. Thailand urged WHO to work with member states in the region in mobilizing domestic resources for prioritizing programs, drawing from Thailand's CCS experience, which draw 70% of program budget implementation from domestic source. Thank you.
Thank you. Thank you for all your comments and observation. Now I invite the WHO Secretary to respond to the observation by distinguished representative.
Thank you, Madam Chair. With your permission, I would like to request Dr. Tushara, our planning officer, to comment on some of the issues raised by the member states.
Thank you, DPM and Madam Chair, Madam RD. Yep, we know that under Madam RD's guidance, we have been implementing this bottom-up prioritization. Some of the members here, they participated in last October with the bottom-up prioritization, and we know it started at the country level, then link up to the regional level, and in fact, our region, we went one step ahead and prioritize the strategic deliverables as well, so that we are more focused. And we really appreciate this collaboration, and we request the same figure and the continuous support so that we can monitor the program budget and move forward. And the country prioritization always linked to the national prioritization, and that's how the regional priorities are done. And this is linked to the SDGs and other global priorities as well. And especially the query from the DPR, the Thailand delegation, on the population size and why 14% is increased. It is decided at the overall level, and it was depending on it was based on the recommendation of the COVID evaluations, and mainly our budget was increased at the $1.2 billion level. But again, if you see now on the PB 24-25, we have moved more into the health system strengthening. That means developing more resilient health systems. And though the population is large, and what we can absorb and to strengthen the health systems, we have increased the budget. Back to you, DPM. Thank you.
Thank you very much, Dr. Tushara. I'd like to make 4 points in response to the various queries and comments made by our member states. The first point I'd like to make is that the program budget 2024-25 has already been approved by the World Health Assembly in May this year. And we are now at a stage of operational planning, which will be over by November this year. And we plan ahead for the next biennium. The second important point is that this is going to be a unique and historic budget, because this is the first time that there would be a 20% increase in assessed contributions, which member states have agreed to. This would increase the predictability of flexible funds that the organization would have. At the moment, the organization works with only 17% of funds which are predictable in a program budget. So it's extremely important that we have more flexibility in the execution of our program. The third important point is that we, as a region, do believe in a joint planning process. We have been doing it for a while, and in that, what is unique with our region is that it's not just a planning process between the national focal points and the country focal points, but it is a planning process which also involves the regional focal points. So it's a 3-level planning process. We have the country, the national focal points, we have the WHO focal points at the country level, and we have the WHO focal points at the regional level. This, we believe, makes our planning more robust and takes into account what the needs of the countries are. The fourth important point that I'd like to make is, which some of you have raised about prioritization. Yes, we do believe in prioritization, and that is why the flagship programs came up. The flagship programs came up after doing an assessment of what the priority health needs are in the countries and how were they ascertained. We looked at the health plans, the national health plans. We looked at the country cooperation strategies. We looked at the various World Health Assembly resolutions. We looked at the RC resolutions. We looked at the burden of disease. And with our honorable ministers and our countries, we worked on priorities which we thought would have a greater impact. And we would have some results to show at the end of the program budget. So as a region, we do believe that yes, prioritization is very important. Otherwise, we spread ourselves too thin and we are not in a position to be able to show what are the results that we've been able to achieve over a period of a biennium. Thank you, Chair.
Thank you, Madam RD Dr. Singh. Excellencies, distinguished delegates, it is time for some physical activity. May I request the Secretary to lead us through about 3 minutes for physical activity break.
Thank you very much.
Please.
Thank you very much, Chairperson. For this afternoon, we will have a slow standing stretching exercise with Bhutanese traditional music. Please stand up, find some little space around you, and be careful for the objects in the reachable distance, particularly water bottle, laptop, and enjoy this Bhutanese lujong.
Yari
Thank you all for your participation. Let us resume the business session. Excellencies, distinguished delegates, welcome back. Let us now discuss the third sub-items of Agenda 7, which is 7.3, Draft 14 General Program of Work, GPW 14. You are aware that the 76th World Health Assembly in May 2023 requested the Director General to draft the 14 General Program of Work, GPW 14, in consultation with the Member States as a technical strategy to underpin the first WHO investment round in the last quarter of 2024. The GPW 14 will replace the 13 GPW 13 1 year early. It will start from 2025, and we include a financing envelope along with strong result narrative for the first WHO investment round. Building on the direction given by the World Health Assembly and drawing on comments received from Member States during the GPW 14 information session, the working paper CAE RC 76/6 provides an initial overview of the major section proposed for the 14 General Program of Work. Also, a consultation document as of 15 August 2023 on the proposed development process and the highest level narrative for GPW 14 is provided as an information document CEA/RC 76/6 info.documents.1. The working paper along with information document at the SPDDM's recommendations are presented to the 76 sessions of the WHO Regional Committee for Southeast Asia for its consideration. I now open the floor for the honorable delegates to make their comments and observations on the sub-items. For the first, I may give the floor for honorable delegates from Bangladesh, please.
Thank you, Sir. We appreciate the WHO Secretariat for sharing the background and update on moving forward with the development of 14th General Program of Work. We acknowledge that this is working paper provide an initial overview of the major objectives proposed for the 14th General Program of Work. These includes the context of 14th General Program of Work, lessons learned from 13th General Program of Work, the overseeing goal and strategic objectives of 14th General Program of Work, and initial consideration for the results framework, financing, enveloping, and financing strategy. We agree with the proposed recommendations for member states. Bangladesh has been contributing actively to the consultation with the 14th General Program of Work and support the development of the monitoring framework for effectively implementing programs. Bangladesh will also actively participate in the evaluation process for 13th General Program of Work. Bangladesh is fully committed to work with WHO and member states towards achieving the triple billion targets as well as strategic priorities of Southeast Asia region. Thank you, sir.
Thank you. Now, I give the floor to delegates from Indonesia, please.
Thank you, Chair. Indonesia underscores the importance of developing the GPW 14 high-level results framework as a strategic tool for WHO. We appreciate the emphasis on outcomes and impact, aligning with the overreaching goal of GPW14, placing countries at the center of defining the priorities and what WHO delivers is a crucial aspect, as it ensures that initiatives are tailored to the specific needs of member states, including Indonesia. We endorse the continued integrated approach of GPW 13 to address health challenges effectively and believe that robust indicators, baseline, and targets will enhance accountability and transparency. Indonesia fully supports the principle of organizational flexibility to enable efficient operation at all three levels. Collaboration across programs and functions is essential for achieving joint work, and we recognize its value in the pursuit of improved health outcomes. We are committed to participating in consultations and discussions on recalibrating the triple billion targets, specifically in areas such as essential health services coverage, financial hardship, climate and health, mental health, disability, physical inactivity, foregone care, and health emergency preparedness and response. We look forward to contributing to the development and testing of an improved UHC index and collaborating with the member states to submit it for the 2025 SDG review. The establishment of a forecasting pipeline to consider drivers of change in outcome indicators and population health metrics is another important step in the strengthening the global health framework. And Indonesia will actively engage in this process. I thank you.
Thank you. Now I give the floor to honorable delegates from Timor-Leste, please.
Thank you, Madam Chair. Timor-Leste appreciate the WHO Secretariat work in drafting the 14th General Program of Work 2025-2028. In consultation with the member state after the 17th World Health Assembly resolution. GPW 14 is to replace the 13th General Program of Work 2019-2025, include a financial envelope and a strong result narrative and draw on lessons learned from the GPW 13 and will be approved by the 77th World Health Assembly in 2024. Timor-Leste is participating in the consultation process for the development of the GPW 14 and pleased to note that GPW 14 build on the strengthening of GPW 13, the priority of the GPW 13 extension paper, the WHO transformation agenda, while incorporating lessons learned, including through the ongoing independent evaluation of GPW 13. GPW 14 will close align the strategic objectives for the 2025-2028 with the GPW 13 extension paper priority area of promoting, providing, and protecting health and improving impact measurement for the use of the country at the country, regional, and global level. The overarching goal for the GPW 14 is to promote, provide, and protect health and well-being for all people everywhere. Timor-Leste believes that fundamental to achieve this goal is the adoption of the primary health care approach that is inclusive, equitable, cost-effective, and efficient, and encompass the full scope of the services across the life course from the health promotion and prevention through essential public health services to treatment, rehabilitation, and palliative care. I thank you, Madam Chair.
Thank you. Now I give the floor to honorable delegates from Maldives, please.
Thank you, Chair. Maldives appreciates the reports by Secretariat on this agenda. Maldives acknowledges the extension to the 13th General Program of the Work GPW 13 2019 2023 to 2025 and the decision of sustainable financing to develop GPW 14 2025 to 2028 as the technical strategy to include financing envelope and a strong result narrative to underpin first WHO investment round. The aim of enhancing the organization's efficiency in respect of strategy, implementation, accountability, and impact is noted. Maldives appreciates the extensive work and recommendations received from the Subcommittee on Policy and Program Development and Maldives for the advice and guidance to the Secretariat on the further development of GPW 14. Maldives believes that GPW 14 will align the strategic objectives of 2025 to 2028 with the GPW 13 extension paper priority areas and improve impact measurement for use at country, regional, and global levels. Ms. Chair, Maldives commits to actively participate in the evaluation process of GPW 13 and contribute to the consultations for the GPW 14. We support the development of the monitoring framework for effectively implementation of programs to achieve real change in WHO operations and capacities at country as well as regional level for advancing health and well-being in the changing global context. Maldives requests WHO to continue its close consultations with member states and support member states to effectively engage in the wider deliberations on impact measurement framework. Thank you.
Thank you. Now I give the floor to honorable delegates from Thailand, please.
Thank you, Chair. Thailand commends the Secretariat for its collective process of GPW 14 development in full consultation with member states and relevant stakeholders, as well as using evidence to support the process. While we are working on the new program of work, there are some remaining challenges from the GPW 13. During the transition from GPW 13 to 14, we need to consider two critical challenges. First, we need triple efforts on unaccomplished triple billion goals, namely universal health coverage, health emergency protection, and promoting good health and well-being. Second, accelerating implementation towards achieving SDGs by 2030, especially those that are off track, including the poor prospect of economic recovery, fiscal space for health resulting from the COVID pandemic. At the same time, we need to maintain the gains from implementing GPW 13, in particular, the linkage between the work of the WHO country offices and member states with effective engagement and support from the regional office. At this juncture, Thailand highlights three homework for the WHO. First, how the WHO's work, especially healthier population billion, can accommodate the super dynamic aspects such as epidemiological, demographical transition, social changes, rapid urbanizations, and technology disruption. Second, how WHO maintain its social and intellectual capital as global health leader in the light of emerging global health landscape and actors, especially highly geopolitical context of the world. Last but not least, how Southeast Asia regional direction, including program budgeting, aligned and synchronized with the GPW14. These are issues that we need to consider. However, the real challenge ahead is the effective implementation to achieve the goals. Thank you.
Thank you. Now I give the floor to honorable delegates from Nepal.
Thank you,
Please.
Madam Chair. Nepal appreciates the consultation document of the 14th General Program of Work 2025-28. It is good to note that there will be a financing envelope and strong results narrative, and GPW14 will draw lessons learned from GPW13. From the consultation paper, it is noted that GPW14 will be developed through a broad and deep iterative process with member states, including global and regional consultations, regional meetings, and that perspectives will also be sought from key constituencies, including civil society, community experts, formal and informal organization, and as well as the private sector. GPW13 was anchored in the health-related SDGs and focused all three levels of organization on achieving a measurable impact on health outcomes. In this regard, GPW14 should incorporate what must be done to achieve measurable impacts and must support countries to accelerate process toward the health-related SDGs and able to operate in a more complex environment for achieving health outcomes. Nepal has used components of the delivery of impact approach to strengthen accountability mechanisms and has benefited from the complete end-to-end delivery for this approach. The overarching goal for GPW14 and strategic objective are well articulated in the document. Nepal looks forward to continued engagement throughout the process of GPW14. I thank you, Madam Chair.
Thank you. Thank you for your comments and observation. May I now invite the secretaries to respond to the queries.
Sorry. Thank you, Madam Chair. I would like to thank all the distinguished speakers for your inputs. As was highlighted, the development of the GPW14 is very, the process that has been put in place is a very inclusive and a country-focused discussion where the discussions right from the beginning have been open and consultation have been ongoing. So far, I think we have already had 2 rounds of member state consultation on this. And at the same time, WHO is driving the development of this with discussion not only with member states but partners, the NGOs, international organizations such as the banks, and then other health partners such as Gavi Global Fund. So this is a very inclusive and fully transparent process of development, which I think gives this GPW14 draft the strength that it already has. In response to a comment about ensuring that impacts and outcome includes a measurement and milestones to be able to track progress and report on that, I would like to assure you that led by Dr. Samira, the ADG in headquarters, who actually is supposed to be here today but could not join us, is at the same time running a parallel group on the development of indicators and milestones while keeping in mind the already developed and agreed indicators for the GPW13. Second comment that I would like to make is that the GPW14 draws heavily on the experiences of GPW13. And the evaluation of GPW13 is now almost complete. And the recommendation or the results from that will be integrated. But even before the GPW13 evaluation is complete, we have been engaging with the consultant firm that is doing the evaluation of GPW13 so that lessons learned from GPW13 are integrated within the concept or the vision of GPW14 as we go forward. So it is planned that by yesterday, 30th October, the inputs on the last draft version is supposed to have received, and the Secretariat will prepare a member state consultation paper again, an updated one for consultation somewhere in the middle of November. So that would be about 2 weeks from now. There would be a new version, a revised version of the GPW13 for member state consultation. So this will continue, and I'm very pleased that our region, many of the countries have expressed their active involvement in that. And we would like to request that all countries please do participate in this, because the word I think that is being used is called co-create. And therefore this should be a product of co-creation. And that is, I think, what we would like to encourage all member states to do that. I don't have any further comments to add unless Madam RD, you would like to add anything.
Thank you very much, DPM. I'd just like to mention that member states may be wondering how GPW14 is coming 1 year ahead and is going to replace GPW13 earlier than expected. This is because in this World Health Assembly that was held in May, which I referred to before, the 76th World Health Assembly, there was a request from the member states to look at a replenishment mechanism. And while looking at the replenishment mechanism, it was decided to have an investment round, which is planned to be held in November next year. The GPW14 will underpin that investment round. And that is why we are considering this earlier than we would have. You all have already mentioned that yes, this GPW14, like GPW13, will have a results narrative, which I've already mentioned before, that yes, we had 6 impact narratives in while we looked at the performance of the year 2022, and we will focus on impact much more in GPW14. We as a region have been focusing on impact, and when we identified our regional priorities, which we mention as flagships, these really developed because we were looking for results and we were looking at impact at country level. So country focus, country strengthening has been at the core of the work of the regional office since some time now. Since 2014, we have been focusing on that to see how we can strengthen country capacity, how we can augment the resources at country level, and that is how 80% of our budget really goes to the country level. If you look at the last biennium, 83% of our budget went to country level. If we look at this biennium till now, 79% is already at country level, and by the time we close the biennium, I'm sure that percentage will go up. And as was mentioned earlier by my DPM, that yes, when we look at this performance, we are not calculating the other country support we extend from the regional office. There's much more to it than what is allocated at the initial stage of budget allocation at country level. Because demands keep coming and we keep complying. And we feel that if our countries are strengthened, we as a region are also strengthened. So the first WHO investment round will take place next year in November. That is the plan so far, in which various countries are going to participate, and the organization will see how it can augment the resources that it has and the flexibility it has with the funding of the organization and the funding of the needs of countries. Thank you, Chair.
Thank you, Dr. Pam and Madam RD, Dr. Singh. This brings us to the end of these sub-items. We will now discuss the last sub-items under Agenda 7, which is 7.4, Sustainable Financing. The working group on sustainable financing was stabilized by the Executive Board to strengthen WHO structures and capacity to fulfill its core function as defined in the Constitution. The recommendations of the working group were adopted by the World Health Assembly in 2022 and included, amongst others, an increase of assessed contribution to increase the share of sustainable financing of the base budget, to explore the feasibility of replacement mechanisms, which we now refer to as the WHO investment round, to broaden further the financing base, and to stabilize the agile member states task group on strengthening WHO budgetary, programmatic, and financing governments to make recommendations and strengthen transparency, efficiency, accountability, and compliance. The working paper CE/RC76/7 presents a summary of the progress in these three areas. After 2 years of discussions, we are now seeing tangibly progress. The World Health Assembly approved the Program Budget 2024-2025, which invites to agree 20% increase of access contribution. The reform agenda is progressing with a broad range of concrete reforms already implemented. Progress of these reforms can be tracked through the member states' dashboards. The WHO investment around is taking form to be launched next year. In this regard, I would like to draw your attention to the information document CEA/RC76/7 INF.doc.1 contains a white paper on the WHO investment around, which was shared by secretariats for consultation and input from a member of states. This white paper defines the main parameters of the investment around, including its proposed modality, financial envelope, risk management elements, evaluation components, amongst others. The regional committee offered a good opportunity for us to provide our collective support to this initiative, to raise our questions, and to contribute to the designs of the important mechanisms that will strengthen WHO financial sustainability. I open the floor for the honorable delegates to make their comments and observations on that sub-items. Now I give the floor to honorable delegates from Bangladesh, please.
Thank you, Madam Chair. We thank the WHO Secretariat for providing an update on the progress made regarding the issues discussed within the working group on sustainable financing. We acknowledge the recommendations, which include an increase in assessed contribution to enhance WHO's financial sustainability. This move is in line with WHO's goal to achieve 50% of the 2022-2023 base budget by the biennium 2030 to 2031, with an initial targeted increase of 20%. Additionally, there is an exploration into the feasibility of a replenishment mechanism to diversify the funding base further. Furthermore, there is an establishment of an agile member state task group focusing on strengthening WHO's budgetary framework. We agree with the proposed actions by the member states as well as by WHO, which were recommended by the Subcommittee on Policy and Program Development and Management. Bangladesh would continue to engage in future discussions on the subsequent gradual increase of assessed contributions, actively engage in consultation on the investment round and implementation of the reforms as laid by the Agile Member State Task Group, and will provide inputs to the Secretariat plan for the WHO investment round. Bangladesh is committed to continue to contribution to financial sustainability of WHO. Bangladesh is fully committed to work with WHO and member states towards achieving the triple billion targets as well as strategic priorities of this region. Thank you, Chair.
Thank you. Now I give the floor to honorable delegates from Sri Lanka.
Thank you, Chair, for giving the floor to Sri Lanka. Sri Lanka perceives the importance and reaffirms its support for the decision of the 75th World Health Assembly on sustainable financing of WHO with a gradual increase in assessed contributions by the member states. The healthcare system in Sri Lanka is surviving a twofold challenge: an unparalleled economic downturn brought on by the prolonged effects of COVID pandemic, compounded by severe economic crisis with a slow recovery anticipated. Given Sri Lanka's heavy reliance on imported medical supplies and equipment, the shortage of foreign currency reserves has significantly affected the availability of essential medicines and the pharmaceutical products in hospitals. Moreover, the health sector faces challenges such as insufficient budget allocations and issues related to inefficiency, lack of governance and accountability in the delivery of healthcare services, all of which have worsened the current crisis. Sri Lanka is committed to formulating sustainable health financing strategies aimed at raising additional funds, ensure equitable access to healthcare, and achieve its national health system goals, especially as it moves towards universal health coverage. Sri Lanka endorses the decisions to have future discussions among member states to adopt the new increase in the assessed contributions to WHO to achieve the agreed targets. Sri Lanka would like to urge WHO to adjust the increase of the assessed contribution by member states considering their respective financial realities, particularly in the aftermath of COVID-19 pandemic and the global economic downturn. Thank you, Chair.
Thank you. Now I give the floor to honorable delegates from India, please.
Thank you, Chair. India acknowledges the WHO's dedication and endeavors to sustainable financing mechanism to ensure adequate and timely funding for global health initiatives by addressing transparency, efficiency, accountability, and compliance challenges. India has always advocated for equitable, affordable, and accessible healthcare services all across the globe. We believe that sustainable financing will be crucial for low and middle income countries to fill the gaps in health service delivery and strive towards achieving universal health coverage. Chair, India emphasizes the WHO investment round should focus on the potential of investing in healthcare infrastructure, R&D, and disease control, both communicable and non-communicable. India is of the opinion that funds may be directed towards addressing key health challenges in developing countries and addressing any perceived biases or imbalances in funding and resource allocation. We also advocate for monitoring evaluation mechanisms to ensure proper utilization of resources and efficient outcomes. Moreover, India suggests exploring novel approaches like outcome-based financing that prioritize the patient-centric, value-based healthcare delivery and continuous improvement in healthcare outcomes. India acknowledges that voluntary funding can play a supplementary role in healthcare financing. So we also believe that relying solely on voluntary funding for healthcare may not be sustainable in the long run. India recognizes the significance of bilateral and multilateral collaborations in achieving sustainable financing. Therefore, we suggest collective and collaborative action from the government, donors, and public-private partnerships to prioritize long-term investments in healthcare infrastructure, emphasizing the need to mobilize domestic resources and explore innovative financing methods to ensure equitable access to healthcare services for achieving universal health coverage. Chair, India acknowledges the significance of Agile Member States Task Force Group report, recognizing the urgent need to strengthen healthcare financing mechanism for sustainable development. As a proactive member, India strongly supports the report's emphasis on innovative financing models, collaboration among member states, and prioritizing primary health care. Additionally, India highlights the need to address rising costs of healthcare services and increase out-of-pocket expenditures. Therefore, it is necessary to provide quality, accessible, affordable, and timely healthcare service delivery to achieve Sustainable Development Goal 3. Chair, India believes sustainable financing is essential for WHO to fulfill its mandate and achieve global health targets. Adequate funding ensures access to quality healthcare, promotes health equity, and effectively responds to emerging health threats. By adopting innovative financing mechanisms and strategic partnerships, WHO can secure necessary resources to address global health challenges and create a healthier future for all. Thank you.
Thank you. Now I give the floor to honorable delegates from Maldives, please.
Thank you, Chair. Maldives appreciates the reports by Secretary on this agenda also. Maldives appreciates the extensive work of the working group on sustainable financing and recall the efforts of PBAC Chair and the Bureau to finalize the recommendations adopted at the 75th World Health Assembly. The increase of 20% in assessed contribution to the Maldives to the program budget 2024 to 2025 is the first step to reach the level of sustainable financing of 50% of the 2022 to 2023 base budget by the biennium 2030 to 2031. Maldives welcome the progress made by WHO with regard to building an investment case supporting the economic programmatic case of GPW 14. We iterate the need to develop risk mitigation plans to ensure transparency. Madam Chair, with an increase in funding commitments by member states, the opportunity widens to cater to the diverse needs of member states. Maldives requests WHO to facilitate the support member states to engage in the consultations and implementations process. Further, we also highlighted the need for reform with regards to diversifying the representation and composition of member states with the workforce of the regional office and country offices. We believe building capacity is essential in moving forward. In conclusion, we applaud the progress made on sustainable financing and the efforts made to implement the action set out in the report and reform plan. Thank you.
Thank you. Now I give the floor to honorable delegates from Timor-Leste. Please.
Thank you, Madam Chair. Timor-Leste is pleased to note the progress made on the 75th World Health Assembly recommendation of the Member State Working Group on Sustainable Financing and congratulate WHO Secretariat for an assessment of the feasibility of a WHO replenishment mechanism in line with the principle set out by the Working Group on Sustainable Financing to the Executive Board at each 152nd session through the Program Budget and Administrative Committee and its 1370 meeting. This new WHO financing mechanism will increase the predictability of WHO funding by encouraging multi-year commitments. It will aim to attract the new donor and enhance political support for the full financing of the base segment of WHO program budget through a year-long, inclusive engagement process that culminates in a high visibility financing event. Timor-Leste also note that first WHO investment around new terminology for WHO financing mechanism will be to resource the organization's 14th General Program of Work by securing the full financing of WHO base budget, enhancing the sustainability and predictability of WHO financing, broadening WHO donor base, improving WHO finance independence, and increasing the efficiency of the organization. We also acknowledge that the 14th General Program of the World will replace the 13th General Program of the World 1 year early, namely in 2025, as first WHO investment round will cover the 4-year period from 2025 to 2028. I thank you, Madam Chair.
Thank you. Now I give the floor to honorable delegates from Nepal, please.
Thank you, Madam Chair. Sustainable financing for health, which emphasizes mobilizing adequate and sustainable revenue for health, is crucial for meeting health-related SDGs, universal health coverage. Nepal, due to low spending from public and pooled funds, the health system financing is highly dependent on out-of-pocket spending, which is currently 54%. Public spending on health, which is a major source of sustainable financing for health in the country, though still low, it has been significantly increased in recent years. The public spending on health, which was around 19% of total health spending in 2016, has increased to 30% in 2020. The share of health spending from the local and provincial governments has increased in recent years, which is a further step in securing sustainable financing for health. The voluntary prepaid pooled funds for health that support pro-poor and pro-health funds, also a source of sustainable financing for health, which have risen from 7.2% to 14.3% from 2000 to 2016, with further increment up to 16% during 2020. Likewise, spending through the National Health Insurance Scheme has been significantly increased in the last 5 years, from 0.1% to 2.4%. As part of the government's further commitment to ensuring more sustainable financing for health, recently a 10-year national health financing strategy has been developed and approved with the objective of ensuring the availability and efficient management of financial resources for better health services, for better areas to quality health services by reducing their financial risks in health services. One of its major strategies is to expand the fiscal space for the health sector through more sustainable financing sources for health. WHO's support in this regard is very important. Sharing resources among countries is equitable distribution and developing common monitoring mechanism for better finance governance are the major issues for sustainable health financing in this region, for which we must work jointly, efficiently. I thank you.
Thank you. Now I give the floor for honorable delegates from Thailand, please.
Thank you, Chair. Thailand, together with other member states, has participated in and witnessed the long process of discussion on sustainable financing at the global level. While increasing access contribution is one approach to expand resources for WHO, equally important is efficient use of the limited resources and monitoring progress, which contribute to change courses of actions. The report offers recommendations to increase transparency, accountability, compliance, and efficiency. Thailand wishes to be updated on the progress and outcomes of implementing these recommendations under the leadership of the new regional director. In addition, Thailand reiterates the importance of adherence to PHENSA, in particular on funding replenishment. This is to avoid conflict of interest that may arise and to maintain WHO's integrity and independence from donors' influence. Finally, we look forward to actively participate in the consultation process on the investment round in the region as well as at the global level, and to provide input to a full plan of investment round that will be presented to the 154th session of the WHO Executive Board. Thank you.
Thank you. Now I give the floor for honorable delegates from Indonesia, please.
Yes, thank you, Chair. We would like to thank the Secretariat for providing a comprehensive report and presentation on the progress of sustainable financing, including the report on the feasibility of replenishment mechanisms. Our commitment to sustainable financing should aim to fully finance the best budget segment of GPW 14 in the investment round, spanning across programs rather than being driven by specific diseases programs. Noting that the WHO Secretariat intends to organize the first WHO investment round in the second half of the 2024, we would like to recommend to the Secretariat as the following. To prepare a comprehensive risk mitigation plan to map and mitigate potential issues, including potential conflicts of interest. Then to create a mapping exercise of potential investors. This will help us ensure the adequacy of funding for each budget segment. Moreover, flexibility in using the budget according to the priorities set out by member state should also be a priority. And then to increase the frequency of consultation with the member states on the WHO investment round. This will help member states to better understand and utilize the investment round. And finally, to maintain access for member states to monitor the budget implementation for transparency and accountability. Thank you, Chair.
Thank you. Thank you, honorable delegates. Now I invite the WHO Secretariat for comments, please.
Madam Chair, with your permission, I would like to ask my colleague, Mr. Pablo Barrera, who is the Resource Mobilization Partnership Officer in the Regional Office, to respond.
Thank you very much, Madam Chair. Thank you very much, Madam Mardi, DPM colleagues, and distinguished delegates, member states of this region. So first of all, to express great appreciation to all of you for your active engagement and participation since the beginning of the work on sustainable finance more than 2 years ago, and your continued support to make our organization stronger and more relevant in the current global context. You have mentioned in your presentations the reasons why sustainable financing is a core element for the health agenda, both in terms of sustainable finance at domestic level for the strengthening of the health systems and access to health, and also for the sustainability of our organization. And that's the focus of the Secretariat's initiatives that are described in the working paper that we share with you. After 2 years of discussions, we are now witnessing very tangible measures towards sustainable finance, all supported by you and designed by you. The first one is the assessed contribution increase, which is the core element of this entire initiative, and the budget for the next biennium already envisages the agreed initial 20% increase, and discussions among member states will define how the further increases will be implemented. The second is the reform agenda, which you have been monitoring and designing yourselves, and at the moment we have a number of very tangible actions already implemented. The Secretariat has established a dashboard for you to follow up the implementation of these reforms through the member state website. And the third is the investment round, and that is probably the most imminent event. We have shared with you a white paper that outlines the main components of this investment round that will complement the increase of assessed contributions to flexibly and predictably fund our program budget for next biennium. It is important that the voices of this region are heard in the design of that mechanism that will define how we fund our organization. The next step is to provide written inputs to that white paper, and our colleagues in headquarters are eagerly hoping to get inputs also from this group, from this region, and to participate actively in the upcoming consultations that will lead to the presentation of the plan to the Executive Board. As per the points that have been raised now by you in terms of risk management, the plan envisages a risk management. We are using the policy of FENSA that was adopted by you, by the member states in 2016, in every engagement we have with non-state actors, not only within the investment round, but also outside, but it will be applied in every investment, in every engagement with the non-state actors in the implementation of the round. I don't think there is any other question or clarification needed. But thank you again for your very active support along this process, which is long, but is so crucial for making our organization stronger and more fit to the current context of global health. Thank you very much.
Just to add a little to what Pablo said, member states would recall that a working group was set up to look at sustainable financing almost 2 years ago, and that was in 2021. The report of that group is available now. Now, basically, there is a lot of demand on WHO, a lot of expectations from WHO, but WHO at times feels compelled to be able to not respond to some of these needs because of lack of funding. And that is why it's important to have sustainable financing. And as Pablo has just explained, a working paper has been circulated in October for member states' comments. I would urge you all to kindly look at that working paper and to make comments. This also is an opportunity. We've captured the comments that you've made, and we would share them with headquarters, because basically this is how it's going to work in the future. There were 3 things that came up there. One is the increased share of program budget, which we have all agreed to in the World Health Assembly, which our member states have agreed to. For the initial 20% increase, ultimately it's going to become 50% increase of the base budget. The second is reform of the budgetary and financing governance of WHO. And that already is being worked upon. And we have seen that the Secretariat has an extensive plan for it. There are 96 actions which would promote deeper engagement with member states for program budget development. And most of these, in fact, 67 of these actions have already been implemented. 27 are in the stage of being implemented. And the third really is the investment round, which I referred to before, and the working paper of which is already circulated. There would be one co-host in each region. So there would therefore be one co-host from our region as well. And to ensure the transparency of this, a dashboard also has been launched. We find that the regional committee, now what has really been highlighted in this working paper is that the need of the organization is for $7.1 billion. And that is a tall order. We are also aware of the fact that we do not have any donors in this region. So for us, it becomes even more important to get engaged with this process, to see how it works so that our member states have enough funding and financing to be able to implement their needs and what they have planned for. Thank you, Chair.
Thank you, Mr. Pablo Barrera and Madam R.D. Dr. Singh. This brings us to the end of the Agenda 7th, Program Budget Matters. Excellencies and distinguished delegates, thank you all for the successful conduct of the second day of this 76th session of the WHO Regional Committee for Southeast Asia. The agenda planned to be taken up tomorrow morning is nomination of the regional director for the WHO Southeast Asia region. Before we disperse, will the secretary wish to make any announcements?
Thank you, Chair. Distinguished delegates, tomorrow morning there will be aerobic tempo, Thai aerobic tempo dance that starts at 7 o'clock. It will run for half an hour in the Desire Hall. Then tomorrow we have a 10.1 agenda, which is nomination of an election of the regional directors. So member states are kindly requested that only 4 delegates will attend that nomination. So basically it will be head of the mission plus 3. This will be in this hall, and it will start at 9:30 in the morning. It will be attended by our Director General, who is arriving tonight. We will have a couple parts of the whole process. First part will be a private, very short session. Then there will be a public session that will be viewable on our social media and other outlets. And of course, you can watch the whole Q&A and presentation in Desire Hall in the room next door. After the conclusion of Q&A and presentation, there will be a private session for voting. After conclusion of voting, we will proceed with the guidance from Legal Counsel to have another public session about the announcement for the regional director-elect. So I would like to reiterate, please remember that only 4 member states will be allowed, including the head of the delegation, allowed in this room for that session. Finally, tonight there is, of course, dinner in this hall. You are cordially invited by the regional director. The dinner will start at 7 in the evening. So please take all your belongings and clear as much as possible because we're gonna have to rearrange the whole hall for the little show that we will have, and of course tables and so on and so forth. So please do not leave your belongings in here. I believe also that Thailand has a short announcement for tomorrow.
Thank you. On behalf of Thailand, I would like to make an announcement that tomorrow at 5:30 p.m. there is side event on social participation at the Desire Hall, which is the next room, and our delegates are welcome to participate in this social participation side event at 5:30 p.m. Thank you.
Thank you, Mr. Robert Chamiskin and honorable delegates from Thailand. The meeting is now adjourned till we meet tomorrow at 9 a.m. Have a restful evening.
Distinguished delegates, I kept quiet because this is not part of the RC, but it is part of our being here. And I've been writing to you all about this evening's cultural events. I have already received what they're going to do from Thailand, Indonesia, and Maldives. From the rest of the other countries' delegates, please kindly give me whatever audio visuals that you have that you wish to play so that I can line it up with our IT and have it ready for our fun evening. Thank you. I will be in the secretariat room there. So please, if you have anything to hand over, please drop by.